Everybody, very good afternoon. Now I'm going to be talking about the management of neurodevelopmental disorder. I'm going to basically carry forward with the beautiful presentation already given by Dr. Utkers. Management of neurodevelopmental disorders, focusing on autism spectrum disorder, intellectual disability, and ADHD. So, what we need is a holistic approach. We already came across this term during the assessment, that assessment has to be holistic. And that every assessment factor is basically trying to find different avenues for intervention, different areas in which we can intervene. So the intervention for these neurodevelopmental disorders, they also have to be holistic, which involves various stakeholders as well. We also need to have a child-friendly approach whenever we are dealing with any children with a mental health related disorder. There also has to be a right-based approach, and then there is this role for a lot of therapy and training-based interventions, not just for children and adolescents, but also for the caregivers, parents, teachers. And also, there should be the management of comorbid child and adolescent mental health disorders and other physical disorders as well, if we can find them. And then lastly, we need to have some avenue of management for caregiver support, without which the whole intervention would be incomplete. So we'll just talk upon these briefly. So the approach to neurodevelopmental disorders basically needs a holistic approach. It has to be child-centric, enabling for the children and adolescents as well as the caregivers. It has to be comprehensive, it has to be right-based and child-friendly. So what does holistic basically mean? It involves the cooperation of various stakeholders, possibly more than that has been listed on this slide, including from parents to the clinical team, to social workers, to physiotherapists, occupational therapists and speech therapists, special educators in schools, school counselors, even community health professionals, as well as policymakers and the local leaders in the community. So, just like, there's a saying, it takes a village to raise a child. So, especially for these children who have neurodevelopmental issues, we definitely need cooperation from all the different stakeholders. We also need a child-centric and a child-friendly approach. Child-centered meaning the child should be at the center of the management plan. The primary client should be the child. Because sometimes when parents bring the child to us, we tend to focus on what the parents are presenting with, what they have as complaints. But then we don't really look into how the child is feeling, what the child is going through, what is more important for the child. So we need to learn to focus on these things as well. And every intervention that is to be applied to the child or to be developed for addressing these issues have to be child-informed. Meaning that there must have been consultation with children during the process of developing these kind of interventions. We also need to be respectful of the children with neurodevelopmental disorders and promote their dignity, which also includes maintaining privacy and confidentiality. We need to have a space where these things can be carried out, where the assessments can be done, where the interviews can be done, where the interventions can be discussed with the children themselves. And they should be included in the decision-making process. We should not be the ones deciding for the children. The parents should not be the one deciding for the children. But then there has to be a mutual discussion, and then we have to come to a conclusion, which includes having discussion with the children. And we need to obtain their assent. We say assent here because we're talking about basically children and adolescents younger than 18. So taking assent from them is also very important. Now, coming to the child-friendly settings. In clinical settings, it can be from the most first step, like the design of the setup, the interiors, the decors. It could be the play spaces, the mats, playgrounds, the toys that I use there, drawing, coloring, or the stationary materials that might be present. Also, having a playroom for evaluation as well as therapy can be very important. And the staff needs to be well versed in terms of child-friendly communication and assessing the children in a child-friendly manner. The home and community settings also need to be made child-friendly and neurodevelopmental disorder-friendly. Like The footpaths may have a certain design. For example, I'm going to take the example of, let's say, people living with blindness. So footpaths having a certain pattern on the ground with certain specific design of tiles, it helps them maneuver across the path. So having, let's say, a wheelchair ramp in the setting can be a very simple but very important design, child-friendly and disabled-friendly design that we can have in the setup. It can also include like having hand railings or handles and neurodevelopmental disorder-friendly bathrooms. A lot of the times these things are overlooked. Also, training of the public and clinical service providers on NDDs, so that when they are in touch with children and adolescents, providing them any kind of service, it comes from a child-friendly and NDD-friendly approach. Now, coming to rights-based approach, children with neurodevelopmental disorders are at great risk of violation of child rights. Some of the common child rights that may be violated are their right to education. A lot of the children may not be enrolled in school or may be taken out of school because of the problems that they are going through, instead of trying to see how we can support them to continue further. They also have the right to be protected from all forms of physical or mental violence, but they might actually be going through a lot of abuse at home and they may not be able to report it. So these might be putting them at risk. Also, there might be a lot of exploitation happening, and they may not be able to enjoy the highest attainable standard of health. So by this we mean that when we try to provide any kind of intervention for children with neurodevelopmental disorders, our ultimate objectivity should be to improve the quality of life, increase their functionality at home, school, and the community setting. By enabling, we mean that there can be therapies and training-based interventions which need to be evidence-based. These can be for children and adolescents, such as self-help skills training, which we do mostly for children with intellectual disability, speech therapy-related trainings, relaxation, stress management skills. These can be taught to the children so that they are themselves empowered to deal with certain difficulties in their regular lives. For children, besides children, for parents, teachers, schools, and even caregivers, there can be other methods that can be taught, like parent management technique is a common technique that we teach these caregivers in handling behavioral issues that the children may develop. School environment modification might be necessary to accommodate and to assist the children with entities to have an easy access in school to different resources. There can be provision of special educators, and sometimes the school teachers may need to undergo certain trainings for this. So what these will do is, this will help not just the children, but also the parents, teachers, and caregivers with the knowledge and skills that is needed to adapt with the difficulties that they face due to the neurodevelopmental disorders. And the approach also needs to be comprehensive. With this, we mean that we should leave no stones unturned. Just like in the assessment, we looked into all the various factors that could be affecting a child's mental health. So when we talk about a comprehensive approach, we need to understand that diagnosing a child with, let's say, autism or intellectual disability or ADHD should not be the end of it. We need to look for other things that's happening, other diagnoses that might be there, other variables and elements that we need to focus on. So comorbidities are a rule in child and adolescent mental health related disorders, so it's not an exception. So once we find one, always look for the others. And we need to liaise with school teachers and community resources. So this can be maybe sending a letter to the school principal or the class teacher, trying to get more information from class teachers, giving them certain inputs through letters on how a particular child could be better handled in school, how they can be supported. And community resources could be playgrounds in the community, it could be child clubs, it could be other organizations that are active in the community, trying to help the children and the families at home as well. And lastly, we also need to support the mental health of the parents and the caregivers. Now, coming to general principles of management. First and foremost is the psychoeducation to the child and adolescent and the caregiver. So psychoeducation basically means giving information about what the problem is. And what are the possible solutions, if there is medical treatment for it, or if there should be training, what's the prognosis going to be like, so giving them an overview of all these things. So if the child or adolescent is able to understand, we need to be able to communicate in languages that they would understand, so with their level of understanding, avoiding any kind of technical jargon, so that we explain it to the children and adolescents as much as possible. But also take time to explain it to the parents. A lot of the times what happens is, the parents come to us, but they've already been through so many other consultations, and they tell us that they don't really know what's happening, we don't really know what's wrong with the child. They might have been told, but then, the information hasn't gotten through. So I think we need to take time to psychoeducate them. The other one is extensive engagement and sensory motor stimulation. This basically means interacting with the child a lot. Talking to them, playing with them, involving them in daily household or commonly done activities that we do on a regular basis. Using the normal daily routine as opportunities to interact more with the child, to help them stimulate the different domains of development. Like, it could be speech stimulation, it could be sensory motor related stimulation. So all these can be done within the home setting as well. Other is providing a general guidance on their well-being, which can include diet, sleep, exercise, having a structured routine, vaccinations, and those kind of things. Other is guidance of managing problematic behavior. Now, we are all well versed with the behavioral theories of how behavioral modifications can be done. So those principles can be used to assist parents to make them able to understand why a child is showing a certain behavior, what can be done to manage it. So behavioral problems should be handled in this way, and we need to liaise with other professionals. A child psychiatrist alone or a psychiatrist alone will not be able to deal with all the issues that a child with a neurodevelopmental disorder has. So there can be other professionals that might be needed, like speech therapist, occupational therapist, psychologist, physiotherapist, family therapist. The list is very long. But then from our setting, since we have limited resources, we should try to mobilize as much as possible. And linking with the available community resources in schools is very important. This has already been talked about. And providing support to caregivers, provision of respite care. And ensuring some regular follow-ups. So, when we talk about this respite care, what it means is the parents and caregivers, they themselves are in a state of stress when a child has a neurodevelopmental disorder. So, we need to focus on how we can also alleviate their stress as well. Respite care basically means allotting time for parents and caregivers to take care of their own mental health, so that they can better support the children and adolescents in the long run. Now, coming to specific interventions. These can be various interventions, like I mentioned earlier. It could be speech therapy, occupational therapy, physiotherapy, self-help skills training, social skills training, and specific interventions for autism. So there are various structured interventions that are globally practiced. We don't have such established structured setup or interventions in Nepal. This is something that needs to be worked on. And also inclusion in school and social settings is very important. Now coming to pharmacological intervention, this is like specific intervention for ADHD. All the other general principles may be as applicable to ADHD as well. Methylphenidate is not available in Nepal, but this is how we can prescribe it if we get methylphenidate in the future. So we can start with 0.3 mg per kg per dose before breakfast, and then this can be gradually increased in a weekly manner. Maintenance can be 0.3 to 0.1 mg per kg per oral before breakfast. These are like the common side effects: insomnia, decreased appetite. There are a few others on the list, but then nothing very significant. Atomoxetine is a new molecule for Nepal because it is now readily available in the market in most bigger pharmacies or hospitals. So we commonly use atomoxetine even in our clinic. So this can be used as 0.5 mg per kg per day once in the morning, or can be used in divided doses with weekly increments to 1.2 mg per kg per day. So dry mouth, some sedation, insomnia, fatigue, these might be present, but we have not had very severe side effects till now. Clonidine is a very common medication which was available since long, is used in different parts of the world for treatment of ADHD. It comes in a 100 microgram tablet. We can start this in divided doses, gradually increase at weekly intervals. The maximum dose is 0.4 mg per kg, and even when reducing, we do it gradually. The common side effect that we see with clonidine is sedation. But sometimes what the parents report is like they've never seen the child, still or calm or sleeping during the day. So sometimes they don't even complain that the child is sleeping for some time, even after taking medications. But usually the sedation kind of wears off in about a couple of weeks. So after that, the clinical effect is only on the ADHD features. So these are the three medications that I would like to discuss. But since methylphenidate is not available, I would like to encourage you all to start prescribing atomoxetine and clonidine for children and adolescents. You can go with one medication first. The other aspect of management now is the management of comorbidities. So various comorbidities can be found, such as other neurodevelopmental disorders. These might be very common. Anxiety disorders, depressive disorders, like Dr. Utkarsh already said, is multiple times more common in children with a neurodevelopmental disorder than other neurotypical children. There can be behavioral problems like oppositional disorders, conduct disorders might be there, epilepsy can be present, and sometimes, in rare cases, psychosis can also be present in children with these issues. And what we need to remember is, without the management of comorbidities, the management of neurodevelopmental disorder is incomplete. And just like Dr. Utkarsh already said, every child is different. So sometimes when we are managing, let's say, a child with autism, and the child has comorbid anxiety or a comorbid ADHD, if we do not manage these, the training and intervention for autism spectrum disorder cannot become successful. It becomes very difficult. Lastly, caregiver support. The caregivers can have various degrees of mental health issues, from some level of distress to severe burnout. We have seen parents who are themselves hopeless, helpless, severely depressed. They ask us, where can we leave this child? Is there a place where we can place them, and then they will take care of the children, because they themselves are now not capable of looking after their own children anymore. So that is the kind of level of distress, of burnout that parents can go through. So the caregiver support should start from the time of initial assessment to the diagnosis to management at the point of contact, as well as every follow-up visit that we have. We need to ask about the kind of problems that they are facing them and initiate some kind of a psychotherapeutic or even pharmacological treatment if needed. Sometimes even in our prescriptions, we write prescriptions or a management plan for children, and then we write for the parent, for the mother or the father, and then we give them a diagnosis, and then we start treatment for them as well in our setting itself. Now, ensuring respite time, as mentioned earlier, is very, very important, because it gives them some space to do things that they can do by themselves, which does not revolve around looking after the children. And sharing of caregiving responsibilities among family members can be one of the ways of providing respite time. The other is having the children enrolled in some kind of a school, or a child care facility, for like a daycare facility an ECT or playgroup even. So when we do that, the parents at least have a few hours to themselves and then they can take care of themselves better. Thank you so much.
I have something. One very tough thing with that. I get some children, not a lot, but most of the children, what happens that some children are brought by some really of my patients. That's you बिरामीलाई यो बच्चालाई इन्टरभेन्सन कहाँ लगेँ निको भयो यहाँ एकदम राम्रो डाक्टर साहब थाहा भयो त्यहाँ गएको हाम्रो गाउँको त्यो एउटा बोलाएर हिँडेको त्यो बोलाएर हिँडेको त्यो निको भयो त्यसलाई निको पालन भयो अब त म ढुक्क भएर people come with a very high expectations. How do you deal? I am sure that happens with you also. I have went a lot of places. Now I find child psychiatrist here. Now my child is different. Sometimes they come with very high expectations. How do you deal with it? That's not.
Real psychiatry. You start, I start, everybody start. Tell them the real thing. Right? Why is really I tell them yes, this is not right. You saw your expectation. You बच्चाले कति इम्प्रुभ गर्न सक्छ सक्दैन यस्तो के हुन्छ हैन यहाँ कस्तोसम्म छ भने अब चाइल्ड साइकियाट्रिस्ट आए हामी साइकियाट्रिस्टले यो भन्नु हुन्न कहाँ टेन्सन लिने यता पठाइदिउँ भन्ने नगरौँ भनेको हामी कहाँ आएर पनि एकचोटि मान्दैन कि तपाईँले त्यही भन्नुभयो मैले त्यो भने अरूले त्यो भन्यो भने बल्ल सुन्छ हैन यहाँ मान्छेले दिल्ली बम्बई मद्रास अमेरिका हैन ठिक हुन्छ भनेर मान्छेले लाखौँ हैन अहिले हेर्नु भयो भने अटिजममा स्टिम सेल ट्रान्सप्लान्ट भनेर यति मान्छेलाई ठगिरहेछ हैन त्यो सम्म हामीले विश्व टेल वाट इट इज म उनीहरूलाई के भन्छु कहिले कहिले कस्तोसम्म हुन्छ भने प्यारेन्ट्सले कुर्चेला लात्ता हानेर जान्छ कि दे डोन्ट एक्सेप्ट इट बट इट्स ओके एटलिस्ट यु हेभ स्टार्टेड द प्रोसेस तपाईँले भनिदिनु भयो मैले भन्ने भोलि अरू कसैले भनिदियो हैन हुन्छ ठिकै छ हेरौँला ठुलो भएपछि राम्रो होला नाटिनु हैन जे छ त्यो भनिदिनुहोस् है आई थिङ्क युल बी डुइङ अ बिग सर्भिस टु देम
अझै के होइन है डाक्टर साहब त्यो के होइन है भन्न खोज्छ धेरैले भन्न खोज्छ होइन जो यो हो भन्नलाई एकदम कति गाह्रो भारी मनले भन्नुपर्छ Like Dr. mentioned, psychoeducation भनेको त one time thing होइन, it's a process. So त्यो भनेको अब उहाँहरू मल्टिपल डक्टर्सको भिजिटमा जान सक्नुहुन्छ. सो सरले भनेको सबैले एउटै इन्फर्मेसन दियो भने त्यो बिस्तारै बुझ्न थाल्नुहुन्छ. र अर्को भनेको कुनै प्यारेन्ट्सले आफ्नो बच्चा न्युरोडेभलपमेन्ट डिसअर्डर छ भने इट्स अ ग्रिफ होइन. सो ग्रिफ हुँदा त्यो डिनायल कति लामो हुन्छ भन्ने कुरा त वी डोन्ट नो. इट मे बी एक्सेप्टेन्स 1 महिनामा आउन सक्छ, कसैको 1 दिनमा आउन सक्छ, कसैको इयर्स लाग्छ. सो त्यो पार्ट छँदैछ. सो द्याट डजन्ट मिन कि हामीले चाहिँ अब ल ठिक हुन्छ चाइल्ड ग्रो आउट अफ इट आफै ठिक हुन्छ भनेर त्यो गयो भने अभियसली दे विल गो एन्ड मिटिङ मल्टिपल डक्टर्स एक्सपेक्टिङ द्याट समवन से ठिक हुन्छ निको हुन्छ. सो द्याट्स वाइ सरको जुन पोइन्ट थियो हामी सबैले एउटै मेसेज दियो भने ग्रेजुअली आई थिङ्क दे कम टु अ पोइन्ट वेयर दे मेक सेन्स. Dr. Guljan, like I have seen that some patients will improve with amoxicillin and low dose. But try to increase the dose to maximum 1.4. They sometimes regulate. Is there a therapeutic window for this? Like that we can combine and do drugs?
Thank you, sir, for the question. Usually, with medication, what we do is with children, we always start very low. And then we gradually increase. Even though there might be certain guidelines saying that you can go up to this, sometimes the side effects become intolerable at a lower dose. For some children, we do increase it gradually to a certain level, and then they start showing improvement. So I think starting low and going slow can be the first principle that we can follow. The other is, as much as possible, we can try one medication. If it doesn't work, and then we switch to the next. Combination medication usually may not be showing significant improvement. It might actually increase the number of side effects that the children might have because of the multiple medications that the child might be in. Usually, we did not talk about this in the slides, but low doses of risperidone as an antipsychotic, but not for the antipsychotic effect. It can be helpful in children with a lot of agitation. For example, in children with intellectual disability or even autism or even ADHD, sometimes there can be a lot of agitation, a lot of aggressive behavior. So the aggression can sometimes be directed at others and destroying property or hitting others, but sometimes it can be directed towards themselves, like they may be biting themselves or scratching themselves. So low dose of risperidone has been shown to be effective in reducing the aggression as well. So usually the combinations that we use are one primary medication and some adjunct. Could be a benzodiazepine for a short course of time or a low dose of antipsychotics, but usually not multiple medications.
Anti-affiliated chalawa चाहिँ कहिलेकाहीँ insomnia, if there is a problem with insomnia, probably clonidine low dose at night could be helpful. अनि पहिलेका मेडिकेसनमा चाहिँ atomoxetine र clonidine को combinationले चाहिँ certain childrenहरूले चाहिँ benefit हुन सक्छ, but we don't do this generally in most of the children. Thank you. Thank you for the presentation and maybe we will answer now. Thank you.
Thank you, Dr. Ranjan Thapa. Disorders in children are a very big concern to the parents. It deals with not only proper treatment and behavior management, but it also revolves around proper counseling to deal with effectively with emotionally engaged parents. The ideas and views regarding the intellectual disability, spectrum disorder, and attention deficit hyperactive disorder in children needs to be explored extensively. Thank you, Dr. Arun Raj Kuvar, Dr. Utkarsh Karki, and Dr. Gunjan Thoju for such an informative session. It was very educative indeed. Now, to felicitate the speakers and the chairperson of this symposium, I would like to request respected Professor Dr. Navaraj Koirala to come on stage and do the honors. I would like to call Dr. Arun Raj Kuvar on stage. Thank you, sir. Now, I would like to call Dr. Utkarsh Karki on stage. Thank you, sir. I would like to call Dr. Gunjan Thoju on stage. Thank you, sir. Now, I would like to call the chairperson of today's session, Dr. Ranjan Thapa, on stage. Thank you, sir. I would like to request all of you dear participants to enjoy the short tea break. We will resume our remaining sessions in 15 minutes. Thank you. Remaining sessions. Let us now gear up for the scientific paper presentation sessions. Today, we have 3 paper sessions, and in each session, we have 5 scientific papers. Each speaker will get 7 minutes to complete their presentation, followed by 3 minutes of discussion of the questions and answers. We will ring the bell after 5 minutes, and the presentation should be completed by the next 2 minutes. The 5 free papers today are Approach for Mental Health Care in Eastern Region of Nepal by Dr. Sandarbha Adhikari, Psychiatric Morbidity in Elderly Patients Admitted to Non-Psychiatric Ward in a Teaching Hospital in Nepal by Dr. Sandhya Subedi, Risk Factors Leading to Adolescent Substance Use, a School-Based Study by Ms. Muna Silva, Prevalence of Anxiety and Depression Among People with Leprosy and its Relationship with Leprosy-Related Stigma by Dr. Pawan Sharma, and Assessment of Mental Health Among School Adolescents at Parsa District of Central Nepal by Ms. Pramila Paudel. I would like to call Dr. Dhanaragna Shakir and Dr. Tanveer Ahmad Khan to take their seats as the chairperson of this session. Thank you, sir. I would like to request the chairpersons to be the panel of judge for these 5 papers. Forms will be provided to the presenters. Please fill it accordingly and submit it to the chairperson. Thank you.
Important session here, pre-paper session. As announcer said, we have 5 papers, and so the first paper is from Dr. Sandarbha Adhikari. So I invite Dr. Sandarbha to go ahead with your presentation. So please note the time and rules in mind.
Respected judges, shall I start my presentation? Good afternoon, everyone. I am Dr. Sandarbha Adhikari. I am consultant psychiatrist from Birtamod, Java. Today my topic is approach for mental health care in eastern region of Nepal. I'll be talking about introduction, methodology, result and discussion, and conclusion at last. As for the introduction, we know that mental and behavior disorder account for about 14% of disability adjusted life years lost worldwide, and it is also said that it comprises of 1/3 of non-communicable diseases. It is said that 2/3 of people suffering from mental disorder worldwide goes untreated, and in low resources country it is more than 90%, as per Patel and Thornikoff in 2009. This study has stated that. And it is also said that people with mental illnesses seldom seek or receive help from mental health services, as per the study done in 2012, Chong et al. Now, even when people with mental health care choose for any services, it depends on what type of mental disorder they are suffering from, and also it is about belief of their family members, as per a Nigerian study in 2012. Agukwa 2012. Now coming to methodology of this study, this is a cross-sectional study done in a hospital setting. It was done OPD-based study, and the sampling was convenient sampling, and number of participants were 80. Now coming to the tools used for this study, the data was collected by face-to-face interview. The tools we used were first was sociodynamic pro forma for sociodynamic characteristic, and the other tool was WHO pathway interview schedule C. This schedule C gathers information about source of care used by patient before coming to mental health personnel, and also section C covers the decision about first care, and it has 7 items like who was seen, how long ago, who suggested for the care, what was the main problem, and how long did problem started, what was the main treatment, and the duration of patient first journey to carer. Now coming to result and discussion, I have discussed this combinedly. Now, at first, coming to socio-demographic variables, we can see the main age in my study was 37 years, and we can also see that the gender-wise distribution was almost equal, and it says that this points toward decreased biasness for treatment seeking. And this study is similar to the study done in 2018, Rai et al. Kathmandu-based study, and what this contrasts the study done in India, Laria et al. 2010, in which the biasness, gender-wise biasness was more. There were 70% male gender, followed by 30% female participants. Now coming to marital status, we can see that about 80% of the sample size was married, and this shows that more than 3/4 were married, reflecting good support system for their psychiatric treatment. And this was the study similar to the study done in 2018, Rai et al. And later, multicentric study was done in 2021, Gupta et al. Now coming to religion, we can see that Hindus were most, with 85% of participants were Hindus, and it was associated with the main problem at first presentation. This variable was associated with main problem. And also we can see the major Hindus, and the most common presentation was of anxiety. There was association between religion and the main problem with which patient present at their first presentation. Coming to ethnicity, we can see that Brahmin dominated almost with 46%, and this ethnicity was associated with preference to first consultation, the main problem patient presented with, and the first treatment they received. And as it is shown here, that majorities were Brahmins, and they preferred local practitioner or hospital doctors followed by traditional healers. This was their preference for their first consultation. Now coming to education, majority were had passed SLC, 40%, and the education level was associated with preference to first consultation. Now coming to occupation, we can see that this occupation was associated with duration of patient journey to first care provider. Now most of them were homemaker, and followed by 25% related to agriculture. Now coming to pathway to care and association, as here we can see that the first contact was equally in local practitioner, and followed with hospital doctors, followed by other native healers. Now this study has contrasted study done in Nepal like Rai et al. And multicentric study done in 2021, Gupta et al. And also from studies from Asia and Africa, where the first contact was traditional healers. But in this study, the first contact was local practitioner and doctors, and we can see this as psychiatrists as the first care provider. In various Indian studies, the variation was 8 to 58%, and our study has also shown that 40% had psychiatry as their first contact. The main reason was the same in this in this study and all study, that there is lack of availability of services and lack of awareness about mental illness. Now coming to how long ago the patient had contact with first care provider, it was seen that in 40% cases the duration was 2.5 years following contact with first care provider, whereas in 30% it was within 6 months. Now we can see that there is acceptance recognition and referral from healthcare providers pointing to a positive mental health seeking. Now who suggested for the care? As we know, we can see that marital support was significantly associated with first help seeking, where more than 2/3 has their suggestion from spouse family, which it shows that the major suggestion comes from family, spouse or relatives, as shown by previous studies. Now coming to the main symptoms, we can see that the main symptom was anxiety followed by somatic complaints, and this was similar to the study done in India in 2016 and 12. And the main factor is how we attribute our symptoms to what
Please come to conclusion.
There is no association to these variables, and conclusion, we can conclude that socio-demographic variables such as ethnicity, marital status, religion and occupation was associated with certain domains of pathway to care, and the first point of contact was either with local health worker or a doctor, with majority prescribing psychotropics. but in majority, the time of approach for first help seeking was better, but approach to the psychiatric help was delayed. This point to the poor mental health literacy, so we need to improve awareness and referral system. At last, coming to limitation of the study, this was a sample taken from tertiary care hospital. This may not be generalized to community setting, and there may be recall bias while they filling the questionnaires. Thank you.
So, any question for Dr. Sandarbha? Yes.
Dr. Sauraha, you said that most of the symptoms are intact.
Yes.
Can you tell me what are the symptoms?
Yes, sir. The symptoms like fearfulness, palpitations, tremulousness, sweating, and uneasiness of heaviness of chest, difficulty in breathing, and such symptoms were
So
considered.
the most common symptoms were cardiovascular.
Mostly cardiovascular, yes, sir.
Okay, if no other question, I have one query. So, have you taken any ethical clearance for that?
Yes, sir. We have taken ethical clearance from the institutional board of BNC Teaching Hospital. We have taken ethical clearance.
So, I think you need to mention that, right? And so, what do you mean by approach? Operational definition of approach in your title, because you said approach.
So basically approach for mental care means about the pathways of care, what patient take for treatment of mental illness.
Thank you, Dr. Sandarbha. I think it's one of the important aspects to see into that. So do you find any difference, because you're in title, it's for Eastern Nepal, right?
Yes, sir.
So whether any difference from Western Nepal or Central Nepal or other part, any your view?
Sir, basically in this case in Eastern Nepal means covering the easternmost part of Nepal, covering almost 4 to 5 districts, because the population represented in Zapad district, they come from 4 to 5 districts like Taplejung to Hilly district and 1 to Tarai district like Morang and Zapad. It means to cover those areas.
Thank you.
Thank you, sir.
We are trying to keep on time.
Good afternoon, respected judges and everyone present here today. I would like to thank the Psychiatric Association of Nepal and my teachers at Universal College of Medical Sciences, Sauraha, for providing me with this opportunity. I am Dr. Sandhya Subedi, Junior Resident, Second Year, Department of Psychiatry at UCMS, Sauraha. Today I am going to speak on the topic psychiatric morbidity in elderly patients admitted in non-psychiatric ward in teaching hospital in Nepal. Starting with the introduction, aging is a natural phenomenon. The number of aging population is increasing worldwide as a result of decline in fertility rate, mortality rates, and improving public health approaches. In Nepal, the Senior Citizen Act 2060 defines people who are 60 years and above as elder population. Since 1991, elderly population has been increasing in Nepal. In 2011, it constituted 81.13% of the total population. In 2021, it has increased by 27.08%, while in 2031, it is estimated to be increased by 25.23%, which will comprise of 10.20% of the total national population. Increasing age brings about many physiological and psychological changes in one's body. More often, it is the physical changes leading to various disease processes in the body that force the patient to visit the hospital rather than the psychiatric counterpart, which may remain unnoticed. Sometimes the lifestyle changes in elderly, for example, death of the spouse, retirement from job, negligence from family, may affect their mental health. The disturbances in mental health, however, are mostly ignored by the patient or their caregivers because of the stigma that prevails in the society. Studies done in past have shown that elderly who are physically ill can have coexisting psychiatric disorders. In those studies, most common psychiatric disorders noticed are depression, delirium, and cognitive deficits. aims and objectives of the study was to evaluate the prevalence and different patterns of psychiatric disorders in elderly patients admitted in different wards of hospital other than the psychiatric ward, to find the association between clinico-demographic variables and psychiatric illness in the elderly patients. Methods and materials. It was a hospital-based cross-sectional study performed at Universal College of Medical Sciences, Bhairava. In the study, elderly patients aged 60 years and above admitted in different non-psychiatric wards were interviewed after an informed consent was taken from them. The following tools were applied in the study, namely self-designed questionnaire including socio-demographic variables, Mini International Neuropsychiatric Interview version 7, Mini Mental State Examination, and Geriatric Depression Scale, Nepali version containing a 15 items questionnaire. Now coming to the results, this figure shows the distribution of patients based on age group. Maximum patients that were interviewed in the study were between the age group 60 to 65 years. This figure shows the distribution of patients based on gender. 30% of the total patient interviewed were male, while remaining 70% were female. This figure shows the distribution of patients based on education level. Around 20 number of patients were illiterate, while 15 each had studied up to primary and secondary level. This figure shows the distribution of patients based on marital status. Around 40% of the 40 number of people were married, while 9 were widowed and 1 was unmarried. This figure shows the distribution of patients based on family type, and maximum number of patients that were interviewed were living in joint family. Now this figure shows the distribution of patients with depression according to the geriatric depression scale. It shows that 34% out of the total patient interviewed had depression. This figure shows the distribution of patients with cognitive impairment based on mini mental state examination. 22% of the total patients had mild cognitive impairment, while 2% had moderate cognitive impairment. This figure shows the distribution of psychiatric morbidity based on mini international neuropsychiatric interview. It shows that 17 of the patients had major depressive disorder, out of which 13 had current major depressive disorder and 4 had recurrent depressive disorder. 2 number of patients had current psychotic disorder due to general medical condition. 2 had current generalized anxiety disorder and 1 had alcohol use disorder. Now coming to the discussion of the study sample included 50 patients, out of which 42% had psychiatric morbidity. This was somewhat close to the study conducted by Awake R in 2000 in Nigeria and Sood A and Singh P et al. In 2006 in India, who found that psychiatric morbidity up to 45.3% and 49% respectively. This slight variation could be due to the differences in geographical and cultural backgrounds. Here, in the study, depression was the most common illness identified, which was 34%. This was similar to studies by Bowler et al. And Sood et al. This was followed by psychotic disorder due to general medical condition, which was 4%, generalized anxiety disorder, which was 2%, and alcohol use disorder, which was 2%. In the study, it was found that 11 of them had mild cognitive impairment, while 1 had moderate cognitive impairment. Most of the patients interviewed were from medical ward and were interviewed within the first few days of admission. The environment and length of the hospital stay was not directly influencing their symptoms. In the study, only 1 patient had positive family history for psychiatric illness. Coming to the conclusion, a majority of the patients suffering from physical and surgical illness thus can also have psychiatric diseases. Therefore, psychological evaluation should be considered as an important component in comprehensive functional health assessment of older people. These were the references used. Thank you.
Any questions, please?
Dr. Sandhya, I think it was a very good presentation. I just wanted to know
what are the medical conditions that are responsible for the psychiatric condition in this case? Number one. And what was the percentage of delirium in this study? Was there any delirium also?
Yes, sir. Two number of patients had psychotic disorder due to general medical condition. Yes.
And was it a delirium?
Not exactly delirium, sir.
You didn't find any delirium cases?
No, sir.
Okay.
I have also small queries. What were the sites, means the setting? Which wards did you look for?
Sir, I went to medical ward.
Only medical?
Orthopedic ward, surgical ward, OMFS ward, also maxillofacial facial surgical ward, sir,
Okay.
ENT ward, and gynecologist.
But I think sir's question you would have found it if you had gone to ICUs, ICUs and post-surgical wards. Immediately after post-surgery and in ICU, you would have definitely found delirium. I think you could have mentioned this in your limitations, maybe. Just a suggestion.
Thank you. So, just one thing, like you have used so many tools, even including the MMSC. Okay, so did you take approval for those tools? How did you approval to use that?
Approval, sir. Yeah, those were freely available tools, sir.
So you will have to check it, okay, before this issue will arise when you will have to publish. That's why, so maybe even at this stage also, please review that. Okay, thank you. So now we will move on to another speaker. Thank you, Dr. Sandhya. And now we will move on to Dr. Muna Silva.
All participants from different places of the country, very good afternoon. I am Muna Silva from Gandagi Medical College, Kaski, Pokhara. Now I am presenting the topic risk factors leading to adolescent substance use or school-based study. Introduction: substance use is a major public health problem worldwide and is common during adolescent period, leading to mental and physical health problems. Globally, 1 in every 10 girls aged 13 to 15 years and 1 in every 5 boys aged 13 to 15 years use tobacco, according to WHO 2019. Drug use among 8th graders increased by 61% between 2016 and 2020. 50% of teenagers have used a drug at least once. Total 43 of college students use illicit drugs. Total 11.2% of overdose deaths are aged 15 to 24 years. NCDS 2020. In Nepal, over 1/3 of drug users, 36.6% had completed lower secondary and 19.8% had completed upper secondary, while 3.6% had completed higher secondary education. Nearly 73.1% current hard drug users had experience of first-time drug intake before they reached 20 years, according to Government of Nepal 2020. A wide range of factors like age, gender, poverty, peer pressure, curiosity, family structure and relations, affordability and accessibility of drugs, media, lack of knowledge regarding its ill effects contribute to the initiation of substance use among adolescents. Guru and Jared, there is a need to study about the risk factors of substance use among adolescents in order to prevent its initiation. Hence, the researcher assesses the risk factors of substance use among adolescents. Objective of the study: the general objective of the study is to assess the risk factors leading to adolescent substance use, and specific objectives are to find prevalence of substance use among adolescents. Next is to identify the risk factors leading to adolescent substance use. Research methods and materials. The research design, quantitative analytical cross-sectional research design was used. The setting was Government School of Pokhara Metropolitan of Kaski district. Adolescent students of selected school grade 9, 10, 11 and 12 were the population of the study. Sample size was 397. It was calculated using standardized formula in prevalence 6.1 in Kaski. This study was run in Kaski district. Sampling technique was Pokhara Metropolitan and Public School was selected using lottery method. 3 wards were selected from total 33 wards of Pokhara Metropolitan. 3 schools were selected randomly from each selected ward. A proportionate stratified random sampling technique was used to obtain a desired sample size. The instrument was a structured self-developed questionnaire. Ethical consideration, first approval was taken from Gondar Medical College Institutional Review Committee, then authority from different institutions, related institutions and participants, written and verbal consent were taken. Data collection procedure, self-administration tool was used. It was taken 25 to 30 minutes per class, and per day data was collected in one school. Then data analysis procedure, SPSS was used, and univariate, bivariate and multivariate analysis was done. Now result, background characteristics of the respondent. Majority of the respondents were age group 16 to 17 years. Male and female, both sexes were almost equal. Hindus were, majority were Hindus. Majority were Janjati. Most of the respondents were from nuclear family. The residents, most of the respondents' residents were in urban place, and place of recent stay was in their own home. Current grade was the 9 to 12. Literacy of the father, majority of the fathers were literate. Majority of the mothers were also literate. Occupation of the father, most of the fathers of the respondent were employed, and they were mothers also were employed, and monthly income was medium. Most of the respondents having the medium monthly income. Then prevalence of substance abuse. In this study, 22.30% were the prevalence. Then association between demographic variable and substance use. There was association among sex of the respondent, grade and occupation of the mother. This was the p value was 0.001 and less than 0.01. Then multivariate analysis was done and adjusted odd ratio. In this, the odd ratio shows the current. The odd ratio shows the current grade of the student grade 11 and 12 having 3 times more risk of substance use than grade 9 and 10. Next was the mother's employment. There is more than 2.5 times more risk substance use in adolescent of the employment mother than unemployment mother. Okay. Discussion. The prevalence of the study was similar with the next study, 18.8, 17.1 in Thailand, 17.7, and contrast study was done in Pokhara. It was 60%. In conclusion, this study concluded various socio-demographic, family-related factors, peer-related factors, individual factors play vital role in substance use. It is recommended to provide a supportive environment from parent, family member, community and school, community, health facility and school-based awareness, counseling and service for adolescents are also crucial to reduce substance use among adolescents. The reference in APA style. Thank you so much.
Dr. Purna, can you declare were you the competitor for the award or not?
Sorry, sir, I am nurse, I am not doctor.
Okay. So are you the competitor or not? Because you have not mentioned it. Are you for the award or not? Have you enrolled yourself as a competitor for award or not? So, questions from the audience, please. Yes, question.
Hello.
Yeah. Thank you so much. Because of time, I could make some detail. I have taken ancient from ancient this concept from the school teacher from related class because the majority of the participants were minor. So I have taken from class teacher with the permission of principal.
बेकार राखेर एकदम कति 3-4 वर्ष कति राख्ने भनेको थियो नि त आफूले
Yeah. Written permission was taken with letter. Letter was sent to the guardian, and guardian gave permission to the school teacher. And sent letter, permission letter to each and every student from student. They take information from the parents, and they permitted to school and school principal allow the class teacher to give the permission.
Yes. Sorry, I missed your presentation sometime. I just wanted to know, because in my legal practice, the peer and pressure, that is the most important factor of suffering youth in the adolescence. And of course, some other factors, the individual factors, various factors are there. But the most common is the peer pressure. So what is your, finding in the study? Because this is the peer pressure that is most important?
Yes, sir. In my school, there are 4 parts. One is socio-demographic risk factor. One is peer factor, one is family factor, one is education related factor is there, but significant, statistical significant is not there in my study, sir.
Any other questions? Okay, so we have of course time limitation. You said occupation also came to be significant.
Yeah, mother's occupation. In other studies shows mother's occupation may be easily accessible or money from the mother to the children. I got this literature, sir.
Thank you, Munaji, for this good project. Thank you. Now we'll move on to the another presenter, Dr. Pawan. Dr. Pawan, please go ahead.
Anxiety and depression among people living with leprosy and its relationship with leprosy-related stigma. So we know that leprosy is a chronic illness with a lot of burden of preventable disability, and then it is seen that the prevalence of psychiatric problems in leprosy is mediated through long duration of illness, physical disability, stigma, and psychological trauma that leprosy brings to patients. So, few studies to cite here from India, from Bangladesh. It's in around 76% of the people with leprosy have some kind of psychiatric illness, 55% depression, 21% anxiety in that sample. And then in another study in Bangladesh, it was seen that the depression was common more than in control groups, and symptoms of depression increased with higher degree of leprosy related stigma and disability. So in Nepal, though it has been declared eliminated disease, but there are high case detection as well as pockets of endemic areas where leprosy is present. And most of the studies in Nepal regarding leprosy is hospital based, and cursory sorts of literature in Nepal, Google Scholar and PubMed showed that there was bulk of literature. So with this rationale, we plan a study with an aim to estimate the prevalence of anxiety and depressive symptoms among people living with leprosy at a special community center or ashram that I'll discuss. So this is the Kokana Arogya Ashram in Kokana, Lalitpur, where Department of Psychiatry, Department Hospital has been giving services. Previously, from on the initiative of Ravi for last 5 to 6 years or more than that. So it's a community of people with leprosy established in 1857. It's a separate kitchen for each family members, and the unit there is a family. And then there are some pictures of people with disabilities still in those centers. And we did a cross-sectional descriptive study with one enumerative sample. The sample size as per calculation came out to be 143, and 143 were eligible, but we could collect 119 patients. 3 moved out and 21 were working outside, and ethical clearance was obtained from Institutional Review Committee, and of course the consent was taken from each patient, and the clearance of the Helsinki was followed. And then in methods, we used a semi-structured schedule which consisted of many variables like age, gender, ethnicity, duration of stay, family history, family visit, details regarding attribution of cause of leprosy to the patient. And then we used hospital anxiety depression scale, and it has been validated in Nepalese population by Vishal et al. And then also we used a stigma assessment and reduction impact scale, that is a SARI scale, that is developed by Burgess et al. For HIV/AIDS, and it was also used in leprosy in other studies, and we translated in Nepali by using the blind translation method, and we did analysis by species 60, and in results we saw that the mean age was 62, and gender male was more, and the duration of stay was 24 plus minus 19 years. And then the literacy, they were majority were illiterate, they were married. Attribution of the disease was, mainly attribution of leprosy to disease was 72%. So supernatural cause it was 13%, and bad deeds was 16%. So, and the involvement of any organ or the disability was in 95% of the patient. So when we took the HADS cutoff as 7 for doubtful anxiety and doubtful depression, it was seen that 39% had depressive symptoms, and then 26% had anxiety symptoms. And when we took HADS score 10 as the cutoff, and it would give a definite diagnosis of depression. So 12.6 had depression and 11.1% has anxiety. And in our second stage, we did a bivariate relationship with all the variables that we had collected, and I've only presented those who were significant for anxiety and depression. And it was seen that gender, duration of stay, attribution to bad days, leprosy-related stigma to be significant in depression and anxiety group. And one step further, we did a multivariate analysis, and it was seen that duration of stay at center and leprosy-related stigma was significant for depression. And then for leprosy attributed to bad deeds and leprosy-related stigma was significant. So here, from this slide, we can note that the leprosy-related stigma was a significant covariate for both anxiety as well as depression. So to discuss, it was the study, so the similar results when we take the probable diagnosis, and then when we look at the general population data from Nepal, National Mental Survey 2019, the anxiety was 3% in general population and depression 2.9%. So it is higher than that general population. And Indian study also gives similar kind of results. So stigma is important correlate, as I discussed earlier. And to discuss a little bit about strengths and limitations. The strength of this study was we had a homogeneous sample of 119 people with leprosy-related disability, and it was a unique opportunity for us because very few asylum or community of leprosy are currently in worldwide scenario. And the limitations were it was a self-reported questionnaire, and cross-sectional study cannot give a cause-effect relationship, and the generalizability to all leprosy patients might not be affected by this study. So to conclude, the prevalence of depression and anxiety symptoms were higher than in general population. We need to screen for common mental illnesses in patients with leprosy, and stigma is a significant correlate for both anxiety and depression. And it signifies the need of anti-stigma strategies, not only for mental illness but also for leprosy. So I have no conflict of interest, and I would like to acknowledge the Psychiatrist Association of Nepal and the PAN research grant that was given around 4 years back. I was one of the recipients, and this was the study that got this research grant. Thank you.
Thank you, Dr. Pawan. So I invite the questions for this very important work.
There is nobody that I will ask. Very long time back, long time. Maybe in 1973, I was working in leprosy clinic. Leprosy clinic used to be in Nepal. And Dr. Mali, Indra Mali, he was the chief. And when I was working as a medical officer, I used to go to overnight leprosy every week. So the most important factor, I think that time, of course we didn't do the study, but my clinical observations, the stigma of course was there. And another is the guilt feelings. Maybe they have some sin, they have done some sin in the previous life. And because this thing they are suffering. So we didn't do any study on depression or anxiety, but stigma and the guilt feelings, that is very common. And the same, associated with that leprosy, that is very common. Regarding this depression and anxiety, the symptoms of anxiety, can you describe a little bit?
Well, sir,
what are the symptoms like?
Well, sir, for that we used a standardized validated questionnaire, that is HADS questionnaire, Hospital Anxiety Depression Scale. And then we did not do a qualitative thing and study with each symptoms. As per the Nepalese validation questionnaire that was validated by Sauraha, that we used. And it consists of all the standard questionnaires, not other kind of culture related or idiom of distress, that we didn't look at that. That was not the objective for our studies.
Okay, any other questions? Okay, so actually congratulations to you. So you are the recipient of PAN award also, and if there is no other question, so my just simple curiosity is, when was it done? Because leprosy, as you said, so very few people left out there. So
it was done in 2021, sir.
Thanks.
So we received the award in 2018, and then there was COVID, and then we could only complete after the COVID in 21 days.
Okay, so duration of stay was quite long there, huh?
Yeah, the duration of stay of the patient was up to 26 years.
26 years. Okay, so that might have some relation.
Yeah, definitely.
Thank you, Dr. Pawan. Now we will move on to another speaker.
I would like to call Pramila Kodal to come with the presentation.
Nepal. I am here to present the findings of my research entitled Assessment of Mental Health Among Adolescents, a school-based cross-sectional study. So these are my contents: background, research question, methodology, research, conclusions, and recommendations. So firstly, the known background. Adolescence refers to the phase of transition from childhood to adulthood, and it constitutes the age group of 10 to 19 years. And it is a crucial period for development of social and emotional habit that is important for mental well-being. Globally, 1 in 7 adolescents experience mental disorder, and mental disorder constitute 13% of the global burden of disease. And amongst them, depression, anxiety, and behavioral disorder are the leading causes of mental illnesses in adolescents. So this is also the background that is known. On the right hand side, we can see the picture representation of the mental status of adolescents in Southeast Asia, evidence for action, which reveals that amongst the 28.5 million of Nepal's population, total 11.8% of total population is constituted by adolescents. And according to the National Mental Health Survey 2020 fact sheet, on a survey conducted among 5,888 Nepalese adolescents aged 13 to 17 years, the prevalence of mental illnesses was found to be 5.2%. Amongst those neurotic and stress-related disorders, the prevalence was found to be 2.8%. And the prevalence of mental illnesses was highest in province number 1, and it was 11.4%. And the prevalence of current suicidal thought was 3.9, whereas the prevalence of lifetime suicidal attempt was 0.7.
So this is the background which is said is a knowledge gap. So only a few studies on the prevalence of child and adolescents mental health have been reported. The failure to recognize and address mental health problems among adolescents is a serious threat to Sustainable Development Goals 3.4 and 3.5. Mental health conditions such as depression, anxiety, and others may lead to behavioral problems such as substance abuse and adolescence. So failing to address their mental health may limit opportunities to live fulfilling life as adults. So it's a compulsion, many times it's a compulsion to rely on the data that are generated in a small scale or somewhere else. Clearly speaking, there is a need for better study design and larger studies to understand its prevalence in order to adequately plan mental health services accordingly. The study aimed to contribute a little step towards building a reference to facilitate programmatic action, especially at the school level. So the research question was, what is the status of mental health among adolescents of selected private school in Parsa district of central Nepal? So now coming to the methodology section, we adopted a descriptive cross-sectional research design to conduct a study, and the study area were purposefully selected to private schools in Birgas metropolitan city, and study population were all the adolescents studied in grade 9 and 10. The study period was November 2019 to February 2020, and the data collection period was second week of January 2020. And we adopted a complete enumeration sampling technique, and all the adolescents willing to participate and present at the time of data collection were included in the study, whereas adolescents who were absent on the day of data collection were excluded from the study. Now coming to the data collection tools and techniques, we use the adolescent self-rating version of Strength and Difficulties questionnaire by Goodman et al. It is a global tool to assess mental health status for children and young people. It consists 25 items comprising 5 scales of 5 items, domains each. The optimum score was compared with a standard cutoff and categorized as no risk, average risk, and high risk of having mental illnesses. So validity and reliability of the tool. So Strength and Difficulty questionnaire is a validated tool, and it is translated in more than 80 languages, but at the time when we conducted the data, we couldn't access the Nepali version, but it is available in Nepali version. So to understand its feasibility to use in Nepalese context, we pre-tested the tool since it was in English language. We pre-tested among 20 adolescents, and reliability value was obtained by computing Cronbach alpha. The reliability value obtained was 0.81. Since it stood above the recommended threshold, it was considered to be eligible to be used for the present study. So data was entered in AP data version 3.1, and descriptive analysis was used. Ethical consideration, so gatekeeper consent was obtained from principal of selected school. Informed regional assent was obtained from each adolescent. Ethical clearance was obtained from Institutional Review Committee of NMC Birgas. So results, total 196 participants participated, mean age was 40, and majority were male, 68.87, and majority 52.55% were male. So this is the mean score of the domain. So total difficulty score was 5.56 with a standard deviation of 1.25. And according to the cutoffs, so 21.9% had no risk, and 26.2% adolescents were at high risk of having mental illnesses. So it is the conclusion, school adolescents are at risk of having mental problems. Risks will never be eliminated but can be minimized. Early identification of risks and timely implementation of risk management interventions at school level may play a vital role in maintaining a sound mental health status among adolescents. So these are the implications. The role of mental health professionals, whether in community or hospital-based, is to manage the risks at primordial and other level of prevention. Psychiatrists and nurses and other stakeholders are responsible to carry out such activities, including the teachers and family during the school and programs, in order to make them aware of mental health. So these are the recommendations. More research that is robust is required in days to come. Future research should use total population or representative sample and valid screening tool to contribute towards providing the true assessment of mental health status among adolescents. So this is the end of my presentation. Thank you.
Thank you, Ramila. So any question from audience?
Can you hear me? results from
in the results, you have said that more than 25% high risk from the assessment scale that was used. So my question is, what was done for these adolescents after you found out that they had some problems?
Thank you for the question, sir. So since it was just a descriptive survey, we planned a mental awareness program, including our masters and nursing students during the student program, so as to create awareness, especially at the school level, not in the particular school, but in the other schools where we conducted the student program.
Okay, thank you. The reason I asked is because any research study that we plan for any population, especially high risk like adolescents, children, that has to usually come with a design that has some kind of an intervention component when we find that there are problems. So conducting a study and then finding out there's a problem, but then having no way of dealing with that, design within the research itself can amount to ethical issues. So that is just my concern.
Sir, I don't get you.
Okay, what I'm saying is when we design a research program and then we find that a certain population group has a problem, this has to be designed within the research itself to navigate them to a certain intervention where they can benefit or get support for those issues. So this can be considered one of the ethical issues because we've talked about consent and assent and all of those things, but then the ethical issue does not just limit within the taking of consent or assent.
Sir, are you talking about the ethical issues? Assent?
No, it's okay.
Okay, thank you, Dr. Gunjan. Very, very important aspect. So we need to, our intention should be to benefit our subject and people who are in problem. So yes, please go ahead.
Actually, I was also one of the helping hands for her in this research. To assure what the nothing and actually, when she said about that result, that has been seen in the different problems in the children. So I personally requested different school authorities to have a school mental health program. So it's very difficult for us to convince them. But me and my department from National Medical College, we went to one institute and then they had a mass session for both the teachers and parents, and we had some conversation to know that how to have this as a very sort of small pilot education. It's a very good question that has to be implemented when we see that there will be a problem in it. That's one thing Thank you very much.
Thank you. So, it seems that your study period is 2020 January, right? Very COVID time. So, before COVID. Okay. I thought so that it might have some implication in your result. So that's. Thank you very much. I think we have had a very good discussion and good presentations. So thank you, Pramila ji. Now I think it's a closure of the. From our side, from chairperson's side, considering the time constraint. Thank you. Doctor.
A very big thank you to all the presenters. Thank you Dr. Kanrazan Shakir and Dr. Tanvir Ahmed Khan. To provide our speakers and the chairpersons with certificates, I would humbly like to call Dr. Nirakar Man Shrestha on stage and do the honors. Honorable Adhikari to please come on stage. Thank you, sir. I would like to request Dr. Sandhya Sukriti to please come on stage. Thank you, Dr. Sandhya. I would like to request Ms. Moona Silwal to please come on stage. please come on stage. I would like to request Ms. Pramila Paudel to please come on stage. I would like to request Dr. Dhanaratna Shakir to please come on stage. Thank you, sir. I would like to request Dr. Tanveer Ahmed Khan to please come on stage. Thank you, sir. Now, I would like to begin with the second free paper session. In this session also, we have 5 papers. Each speaker will get 7 minutes to complete their presentation, followed by 3-minute discussion of the questions and answers. We will ring the bell after 5 minutes, and the presentation should be completed within the next 2 minutes. On the topic prevalence of anxiety and depression in epilepsy, a cross-sectional study from Tertiary Care Hospital of Western Nepal. With the topic medication, taking behavior among patients in bipolar disorder, a qualitative study, we have Dr. Abash Nirauda. Stressful life events and clinical characteristics in acute and transient psychotic disorder, a hospital-based cross-sectional study, will be presented by Dr. Vinita Regni. Blood boundaries of the brain, the topic will be presented by Dr. Ashish Datta. And lastly, emotional and behavioral problems among Nepalese school-going children. This topic will be presented by Dr. Jasmine Ma. I would like to call Professor Dr. Nagaraj Koirala and Dr. S.B. Oja, sir, to take their seats as the chairperson of this session. Thank you, sir. I would like to request the chairpersons to be the panel of judge for these 5 papers. Over to you, sir. Thank you.
Presentation, and I can see the young faculties, young participants. I think this is the experience. The presenter will have an experience presenting in 7 minutes presentation and interaction 3 minutes time. So it's a learning experience, and for the audience also, it's for you learning experience that how you can present. So I think without wasting time, I would like to request the first presenter, Anmol Bandhu Karki, please. So you know the time frame. I'm sure that we'll have live discussions. Thank you.
Namaste everyone. I am Dr. Anmol Bandhu Karki, Junior Resident in the Department of Psychiatry. I would like to thank Psychiatric Association of Nepal for organizing PanCon 2022 and Department of Psychiatry UCMS for providing me an opportunity to present on the topic prevalence of depression and anxiety in epilepsy, a cross-sectional study from the Tertiary Care Hospital of Western Nepal. Coming to the introduction of the study, depression and anxiety are a frequent psychiatric problem in people all over the world, and they are even more common in the people with chronic illness like epilepsy. This depression and anxiety has a substantial negative impact on one's quality of life, yet it is an illness that can be effectively treated. The prevalence of epilepsy has been estimated to 5 to 30 per 1,000 population. Depression can directly increase the seizure frequency through the mechanism of sleep deprivation. So, failure to recognize the depression or inadequate treatment of depression can lead to a suicide. Similarly, anxiety can also have a profound influence on one's quality of life with epilepsy. The objective of this study is to assess the prevalence of depression and anxiety disorder in the patient with epilepsy and to study the association between the clinical demographic profile and the anxiety and the depressive disorder in the patient with epilepsy. It is the descriptive cross-sectional study performed in Universal College of Medical Sciences, Sauraha, which is a tertiary care hospital located in western region of Nepal. In this study, we have used non-probability propositive sampling technique, and the sample size taken was 58. Those patients above the age of 18 years, those who were diagnosed with epilepsy for at least 6 months without any other neurological comorbidity at the time of psychiatric evaluation were included in this study. In this study, the research instrument used were the self-administered questionnaire, which included socio-demographic profile, modified Kupuswamy socio-economic status scale in context of Nepal 2019, and Nepali translated version of Beck anxiety inventory and Beck depressive inventory. Those were validated in Nepal. Now coming to the result, out of the 58 patients, most of the patients were from the age group 21 to 40 years. They were 36 in number, and the minimum patients were from the age group 61 to 80. They were 3 in number. Most of the patients were male, that is 57%, and the 43% of patients were female. Similarly, 66% of patients used to live in joint family, whereas 34% of patients were from the nuclear family. Now, this is the distribution of patients with epilepsy based on socioeconomic status scale. Most of the patients were from the upper lower class, that is 19 in number, and one number of patients were from the lower class. Similarly, among 58 patients, 24 number of patients were seizure-free since last 1 year, whereas 25 number of patients has a seizure frequency from 1 to 10 per year, whereas similarly 5 patients had a seizure frequency more than 10 per year. Similarly, in this study, 14 patients had the positive family history of mental illness, whereas 86% has a negative family history of mental illness. Now coming to the anxiety level in the patient with epilepsy, out of the 100%, around 44.8% of patients has anxiety, in which 29.3 has mild anxiety, 10.3 has moderate anxiety, and 5.2 has severe anxiety. Now similarly, coming to the depression level in the patient with epilepsy, out of 100%, patient with depression in this study was found to be 56.9%, among which 19% had mild depression, 28.8% has moderate depression, and 12.1 has severe depression. This table 1 shows the association between the anxiety and the selected clinical demographic characteristic of the patient. This table shows that there is a significant association between the type of the family and the family history of mental illness and the anxiety level in the patient with epilepsy, whereas this table also shows that there is no any significant association between the age of the patient, gender, and the frequency of seizure per year and the anxiety level in the patient with epilepsy. Similarly, this table 2 shows the association between the depression and the selected clinical demographic characteristic of the patient. According to this table, there is a significant association between the frequency of seizure per year and the depression level in the patient with epilepsy, whereas there is no any significant association between the age of the patient, gender, type of the family, and the family history of mental illness and the depression level in the patient with epilepsy. Coming to the discussion of the study, the prevalence of anxiety in patients with epilepsy in this study was found to be 44.2%. The finding was higher than the study conducted by Singh PM et al. In 2019 in Nepal Medical College, which showed about 36% of anxiety in patients with epilepsy. Similarly, the prevalence of depression was 56.9% in present study. This finding was higher than the study conducted by Adhikari AP et al. In 2014 at TUTH, which showed 36.8% of depression in patients with epilepsy. This difference in the prevalence of anxiety and depression may be due to small sample size, difference in methodology, and maybe the socio-economical and cultural factor in our society, as well as we have looked at the point prevalence rather than lifetime prevalence. There was a statistically significant association between the anxiety and the type of the family and the family history of mental illness. The present study also showed that there was a statistically significant association between frequency of seizure per year and the depression level in the patient with epilepsy with p-value 0.03. The study done by Jacob et al. In 1996 showed high prevalence of depression in uncontrolled seizure as compared to the controlled seizure. Coming to the conclusion of the study, more than 1/3 of the patient with epilepsy had anxiety, and more than half of the patient had depression. Patients with epilepsy who receive the effective therapy for anxiety and depression may have improvement in their quality of life, functioning, and self-care habit, which will ultimately lead to the treatment success. Thank you. These are the references.
Okay, Dr. Arnold, thank you very much for your timely presentations, bringing prevalence of anxiety, depression, in epilepsy. And yes, sir, any questions?
The types of epilepsy. Which type of epilepsy? What is generalized tonic-clonic? What is simple seizure? What is complex partial seizure? What is absence? What type of seizure it was? Number one. Number two, in anxiety symptoms, in anxiety, what the most common symptom you find is the cardiovascular or the other symptoms, the neurological, respiratory, which symptoms you found? Okay? You got a question, no?
Yes, sir. In our study, most of the patients had a generalized tonic-clonic seizure, sir. And in anxiety symptoms, most of the patients has anticipatory anxiety. Sir. They have a fear of having upcoming seizure in them, sir.
Okay, Dr. Arnold, anybody?
Were they on treatment or not?
Yes, sir.
Were they on treatment?
On treatment?
Yes, they are on treatment.
And the seizure was controlled or not?
Some of the seizure were controlled, some were not controlled, sir.
Okay, anybody? Maybe last thing, may I ask you, after this research finding, what is your recommendation to the young psychiatrists? What do you think?
Sir, those patients who come to OPD or any other setting who have epilepsy, we should not ignore the symptoms of anxiety and depression. We should look over for the depressive and anxiety symptoms also, and we should treat accordingly.
Consider. Okay, thank you very much. So, next speaker. Yes, thank you.
Thank you so much.
My topic for today is medication taking behavior among patients with bipolar disorder. This is a qualitative study. Without further ado, I would like to move on with the study. So I have nothing to disclose. So why did I choose this study? Well, this phenomenon is very less studied, often neglected. We daily encounter patients with non-adherence in our OPDs and wards, clinics. It's a frequent yet a complex phenomenon. And we, as psychiatrists, if we do not study the behaviors, who else will? So, coming to the introduction, as we all know, bipolar disorder is a chronic psychiatric disorder, the remitting relapsing course, and non-adherence is very significant in clinical practice. So, by medication taking behavior, what I mean is adherence, which is commonly used. Previously, a lot of studies have used the word compliance, but it is better replaced by adherence these days. So, WHO beautifully defines adherence by extent to which the patient's behavior, taking medications, following a diet, and or executing lifestyle changes corresponds with agreed recommendations from a healthcare provider. We all know if a patient does not take his or her medications, the treatment is ineffective, it worsens the course and outcome, impairs the quality of life, increases the cost of care, and also increases the risk of self-harm. So how frequent is non-adherence? In various studies, it is seen around 40 to 50% of patients in any chronic psychiatric illness. It is not only for bipolar disorder, this is for bipolar, but in most of the chronic illnesses, it ranges from 8 to 68% and even more. So it is same for mood stabilizers, antipsychotics as well. So the objective of my study was to explore patients' perspective on factors influencing medication taking among those with bipolar disorder using qualitative methods. This was a study I did in PGI Chandigarh and it was ethically approved from there as well. So I tried to see the research that was done in Nepal. I could find these two studies which also showed that non-adherence led to relapse and also side effects by medications also led to non-adherence. So what was my method? My method was mostly qualitative, but initially to categorize the disorder, I have used these scales. And for medication adherence, I have used two standardized scales, which is the compliance rating scale and the medication adherence questionnaire. So we divided into two groups, adherent, roughly around more than 75%, and non-adherent, less than 25% of those who took the medications as prescribed. So my sample size was 10 each for them, both of them. So in my study, briefly, it's a complex thing, but I've tried to summarize my study. So first we recorded the interview, and then we made transcripts. Then later on, we extracted themes from those transcripts, then compared the themes to a level in which there was saturation and no more themes could come. And then we found that which themes were common and significant in a study. So how did I get causes? I mean, how do you know what to compare, what not to compare? So the three standard models in medication taking behavior are these, which are the health belief model, self-regulatory model, and the necessary concerns framework. So I'll just read out to you a few of the transcripts that I have found out. This is for the awareness of the symptoms. The doctor asked, what is the illness that you had earlier? And the patient replied, I used to feel sad, had no interest in doing anything. I had attempted suicide thrice. I used to be very distressed, I did not feel like interacting, I had a strange type of agitation. And when I was in the high phase, it was opposite of sadness. I used to remain very happy, speak a lot, ate more, ran around, and even I smoked more. I will try to speak only on the important ones. So one of the patients tried to explain his symptoms this way. The day when it all started, I was very upset. I spoke in a loud voice. I went to the market, I went to all the shops, I hit people, my blood pressure was very high. That is why I had this attack. Then everyone said that she's upset because she's under a lot of stress. When I was sad, I did not want to talk to anyone. I used to do my work and then sit alone and not talk with anyone. I did not enjoy anything. Faith healing, one of the patients explained, everyone who came to me used to say, she does not have any illness, this is due to effect of black magic or jadoo tola, which they use over there. A faith healer also told me so. We visited the faith healer earlier. There were 5 spirits hovering around me. Among them, one had come so near to me that we had to perform rituals. The faith healer also told us that the illness started because someone had fed me something. So, instead of going through the whole transcript, I'm just trying to give you an idea as to how they explain the illness per se. And even regarding here are side effects, regarding weight gain and building of saliva, having rigidity of arms. One of the most important factors was doctor-patient relationship. When we asked, can you freely talk with your doctor? One of the patient replies, doctors do not talk with you at all. They just write the medicines and send you out of the room. And they see you in the beginning, initially they talk a little bit more, but later on they do not ask you anything. And does talking to the doctors help? Yes, it builds up my confidence. I'm able to share a lot of things with the doctors which I'm not able to share with the family members. This is one of the most significant factors in my study. Now, because of the time constraints, I would like to just go to the stigma part. Do you think people with mental illness are looked down upon? They say yes, absolutely so. People think that the person who is mentally ill is insane. This affects the patient's image. He loses respect, his words don't carry much weight. It's not just other people, but with your own family members as well. Children start to think we are mad. Then why would they listen to me? In a meeting of 20 odd people, I stand in a corner. Why didn't they call me? Because they thought I was mentally ill, and so on and so forth. So in the result, the following were the most significant part. So commonly we found in our study 60 themes. So there were basically 60 reasons why the patients were not adhering to medications. These are the most significant factors. And coming to the conclusion part, not that it's extremely common, a multitude of factors and a complex phenomenon is associated with it. And this study highlights the need to study this aspect in greater detail. It is something we see clinically. It is of utmost clinical utility that we study this aspect of our field a lot more. Regarding the role of family, from my study was to awareness and insight, calendar charting, accompanying the follow-up, express emotions, and for treating doctor, right? Okay. Finally, I would like to say the most expensive pill is the one that is not taken or taken inappropriately. And I think it is time for us to start with qualitative studies. Thank you so much.
Thank you, Dr. Aras. Again, any comments, remarks? Maybe yes. Sorry.
It was a beautiful presentation and I was looking for it. My question to you was, did you use any software to generate the themes like NGO and STI. And second was, you said you took 10 from the adherent group and 10 from the non-adherent group. So what was the diversity of a population that you took? Did you take anything into measure of a socioeconomic background, age, or some kind of a diagnosis? So could you put light on it?
Thank you for your question. I did not use any software for generating the themes. Okay, so when I was in Chandigarh, the patients normally spoke in Hindi. Okay, so it was mostly a purposive sampling. So that was a limitation of my study. It was a cross-sectional hospital-based study. So that diversity probably was missing. And that is why it is more, benefit of doing a particular study in community. But even having said that, it does not detract us from finding out themes which are equally essential for us to determine adherence.
In my experience, in my clinic, I think the adherence rate is more than 75%. More than 75%. And only 25%, I think, they are non-adherent. And that is also because, number one, no insight. In bipolar cases, especially in the manic stage, sometimes even in psychotic depression, there is no insight. And on top of that, the faith healers, the naturopathic doctors, the homeopathy, the Ayurvedic, they keep on telling, if you take this allopathic medicine, your kidney will be damaged, the liver will be damaged, don't take it. So many patients they tell me these things. And this is the reality. And the most important thing, the explanation to the patient about the diagnosis. What is the diagnosis? And the treatment plan we have to do together with the patients, and we have to explain how long the treatment will go. And if you don't adhere to the treatment plan, then what will happen? And if you adhere to the treatment plan, what will be the outcome? I think this thing, if you talk about 10 minutes after the diagnosis, I think the adherence rate will be increased. Thank you.
Thank you, sir. Thank you, sir. If I
नमस्ते मलाई तपाईहरुसँग एक दुईवटा कुराहरु डिस्कस गर्न मन लाग्यो तपाईहरुले रेजिडेन्ट स्पेशली आई वुड लाइक टु आस्क what you understood and यो क्वालिटेटिभ र क्वान्टिटेटिभ यो स्टडी उहाँको क्वालिटेटिभ थियो इट्स नट अ क्वान्टिटेटिभ र तपाईहरुले यसको बारेमा कतिको बुझ्नुभयो है अरूभन्दा यो फरक छ because it's not a quantitative, it's a qualitative study. So you must have a knowledge. Why people, they want to carry out qualitative study instead of quantitative. The purpose, the objective of qualitative study is totally different than quantitative study. If you want to know in-depth analysis, in-depth knowledge of a phenomenon or happenings, to understand in-depth of the phenomenon and to make a hypothesis. These are the two reasons. For that, you need to have a qualitative study. Qualitative को सबभन्दा सुन्दर पक्ष के हो भने कुनै पनि फेनोमेननलाई त्यसलाई डीपमा एकदम डेप्थमा एकदम बटममा तपाई जान्न चाहनुहुन्छ भने you need to have a study qualitative instead of quantitative. Quantitatively तपाईको न्यूमेरिकल फेनोमेननमा मात्रै जान्छ तपाईं त्यसमा डेस्क्रिप्टिभ स्टडीहरु तपाईको चाहिँ डेस्क्रिप्टिभ तपाईको चाहिँ स्ट्याटिस्टिक्स युज गर्नुहुन्छ भलै त्यसबाट आएको जुन नम्बरहरु हुन्छ त्यसलाई तपाईको ट्रान्सक्राइब गरेर त्यसलाई तपाई चाहिँ स्ट्याटिस्टिकल टुल्सहरु युज गर्नुहुन्छ त्यो अलग कुरा हो तर त्यसमा तपाईको चाहिँ के भन्दाखेरि मिन मेडियन मोड भनेर तपाई अथवा अरु चाहिँ पी भ्यालु यो भ्यालु त्यो भ्यालु भनेर डाइरेक्ट राख्न सक्नुहुन्न तपाईले ट्रान्सक्राइब गर्नुपर्छ इन डेप्थमा बुझ्नुपर्छ र नेक्स्ट स्टेप तपाईको चाहिँ बुझिसकेपछि के चाहिँ हाइपोथेसिस बन्न सक्छ र त्यो हाइपोथेसिसलाई तपाईले प्रुभ गर्नलाई अगेन यु नीड टु गो इन्टु क्वान्टिटेटिभ स्टडी बुझ्नु भएन त्यसकारण यो स्टडी के थियो भन्दाखेरि ही ट्राई टु अन्डरस्ट्यान्ड इन डेप्थ द फेनोमेनन रादर देन टु क्वान्टिफाई इट द्याट वाज वन्डरफुल तपाईको चाहिँ उहाँको प्रेजेन्टेसनको उहाँको स्टडीको एउटा सुन्दर पक्ष के थियो भने यु वान्टेड टु अन्डरस्ट्यान्ड द फेनोमेनन रादर देन टु क्वान्टिफाई बुझ्नु भएन त्यसकारण अब तपाईहरुले यसबाट चाहिँ के भन्दाखेरि बुझिसक्नु भयो भने अब हो कि होइन अब तपाई पर्सेन्टाइलमा तपाई चाहिँ पर्सेन्टेजमा तपाई चाहिँ स्टडी गर्नुहुन्छ र अब म ह्याभिङ सेड दिस डक्टर आवाज वन्डरफुल मैले चाहिँ धेरै पछि धेरै साल है मेरो यो 30-40 वर्षको यो प्र्याक्टिसको साइकियाट्रीमा द फर्स्ट टाइम आई एम लिसनिङ अ क्वान्टिटेटिभ स्टडी द्याट हेज बिन प्रेजेन्टेड बाई समन इन कन्फरेन्सेस अर सिएम मलाई तपाईँलाई के सोध्न मन लाग्यो भने what hypothesis you could have derived from your study? Would you like to make any hypothesis now further?
Yes, sir.
तपाईँले बुझ्नुभयो सबै गर्नुभयो अब मैले तपाईँको स्टडी हेरेर तपाईँ मलाई के हाइपोथेसिस दिन सक्नुहुन्छ कि जुन चाहिँ म क्वान्टिफाई गर्न सक्छु फर्दर स्टडी यु अन्डरस्टुड मी
Yes.
यु गट मी
Yes.
थ्याङ्क यू I want to hear it from you.
Yeah, I will try and answer the question, sir, to my best of ability. What I did realize is the hypothesis I could formulate from this study is whether one or various factors, including the time spent in the OPD with the patient, determines adherence. That is one major thing that I could give forward by this study. And in this time, what I mean, in this time I mean educating, maintaining a good rapport with the patient, bringing family members in the treatment net, giving a regular follow-up date, also writing medications with low cost, monotherapy, not complex prescriptions, so on and so forth.
Okay. अझै म तपाईँहरूलाई है रेजिडेन्टहरूलाई है म त्यहाँ चाहिँ हाम्रो चाहिँ कन्सल्टेन्ट साइकियाट्रिस्ट एकदम सिनियर मोस्ट भर्खरै लाइफ टाइम अचिभमेन्ट हामी है उहाँहरूको इन्ट्रेस्ट होइन यहाँ हामी थुप्रै छौँ तपाईँहरूलाई हाइपोथेसिस दुई किसिमको हुन्छ एउटा नल हुन्छ एउटा अल्टरनेट हाइपोथेसिस हुन्छ नल देयर इज नो डिफरेन्स अल्टरनेट देयर इज डिफरेन्स त्यसपछि एरर हुन्छ टाइप 1 एरर टाइप 3 एरर अब त्यो विषयमा नजाउँ अब मैले तपाईँले सोध्न खोजेको डक्टर आवास what null hypothesis or alternate hypothesis you could have made derived from your study, from this study. Null hypothesis that you need to refute, you need to prove alternate hypothesis, there is no difference and there is difference.
Yes, sir.
So in terms of null and alternate hypothesis.
Regarding that, I would like to say...
I would like to give you full marks.
Thank you so much. So I would like to say, whether only patient-related factors or any illness or doctor-related factors also determines adherence. That would be my knowledge of this for this case.
I am satisfied. Thank you. Immediate past president of Indian Psychiatrist Society. We are blessed that he is here with us.
Good evening, ladies and gentlemen. This is Dr. Ashish Datta, and it's a moment of pleasure to have Gautam Saha sir right here. It's quite encouraging, sir, and we're feeling really blessed with your presence. I'm going to present on things related to how at times it becomes difficult to delineate clearly whether it's a functional domain disorder or a neuroanatomical or a neurological disorder in psychiatry and neurology. So because of paucity of time, I'll briefly present the cases. I'll straight away get into the cases. This is the third presentation in this series of blood boundaries of the brain. The first one and second one I had presented. The first one I had presented in PanCon 2021 in Vietnam, and the second series was presented in Psychiatric Federation Conference in Kolkata in 2021 itself, and this is the third in the series of presentation. Basically, the first case I would like to present is a titled Seeking Comfort in Stroke. Appears quite paradoxical. How can one seek comfort in stroke? But as Freud had mentioned very beautifully, all defenses have in common the protection of the ego against instinctual demands from the ego. And as we shall see, the stroke was actually not due to some ischemic changes or the hemorrhagic changes, but it was because of a panic attack and panic disorder which the patient had. So, this patient is a 29 years old male who actually presented with acute left-sided hemiplegia, facial deviation to the left and root eyelid on the left. So at the first glance it appears that it's a case of acute stroke, and then definitely a stroke protocol is activated and the emergency team would rush for thrombolysis, considering that it's a case of stroke, but it's actually not an organic or neurological stroke, but it was actually a functional case of stroke. As you can see, there's a blitz. If you notice it, the facial deviation was on the left. A person with left-sided hemiplegia will have a facial deviation towards the right if it's a real stroke. And because the patient was a paramedical staff and he had a little knowledge about what is stroke and all this, so that actually helped him mimic the symptoms of a stroke during an acute episode of distress. It was treated as a stroke initially, but a psychiatric consultation was sought when things were not matching, and it turned out to be a panic disorder. And the moment he had that symptom of so-called stroke, that particular time there was an acute precipitating factor. It was quite stressful for him to handle that, and that actually was expressed physically in the form of acute left-sided hemiplegia. The patient was put on acetylcholine 20 mg and amitriptyline 25 mg, and that led to significant improvement. And the patient had seen at least 1.5 months ago, and now the patient is doing really good. And just to support my findings, a study published recently, it was in 2020, it had mentioned, it's even mentioned in the literature that the hyperacute clinical diagnosis of stroke remains a major challenge, as 1 in 4 suspected cases turns out to be a stroke mimic. So 4 cases out of 4 cases which you see, which you think is a heat stroke, now one must kindly consider a psychogenic possibility as well. The second case is muddiness. Mutism, is basically the word used to signify a person who actually is in deep thoughts and all. So this was a 14-year-old boy who, while writing his exams in 9th grade, it suddenly developed aphonia. He was unable to speak. So it's quite easy to, and when ENT consultation was done, all his vocal cords were normal, so all organic phenomena were ruled out, and then we came to a conclusion that it is a psychogenic aphonia, probably due to stress of the exam in a 14-year-old boy. But then a glitch in this case was, this boy, he also had in his MRI had left inferior frontal lobe signal changes in his MRI. So that would suggest that it's probably aphasia phenomenon happened. But there was again a glitch. Clinical difficulties arise in such times. It was in the Broca's area, there were high signal intensity changes, but although that finding was there, that was not leading to the psychogenic aphonia, but or the aphonia itself, because the speech articulation was normal. In aphasia, we usually have problem with the speech articulation. So this particular clue helped us find out that it was not organic and it was purely a psychogenic phenomenon. So many a times we come up with functional symptoms, patients are having functional symptoms, but at the same time some MRI signal changes, they'll tell you, okay, I have to be cautious in diagnosing. So the important finding in this case was, basically we should always anticipate. Like for example, if this patient presents in future with articulation difficulties, then I would consider the frontal, the Broca's area signal changes again in future, just to find out whether it is organic or psychogenic. This is very interesting. So we should always keep our minds open while we're assessing cases presenting with functional overlap. The third case was maimed by mosquito. Basically, this guy was completely devastated. His brain, basal ganglia was completely devastated. But the glitch in this case was he had presented with behavioral changes and placidity. His father had brought him to our OPD saying that he's completely changed personality and he's not talking well and remains placid all the time, and it was acute in origin. And it was treated as a depressive disorder with an inpatient admission at a hospital for approximately 1 month. When there was no improvement seen, then the patient was brought to our place. There, when we took the history, we found that there was a history of acute onset of fever when the symptom changes had occurred in this person. And then when we evaluated him, the MRI head, then we saw this big lesion in his left basal ganglia. If I'd like to zoom in. There's no option for zooming it, but the one highlighted in red is the area of the left side of the basal ganglia was actually severely damaged. Even to lesions, certain lesions extending up to the thalamus. Then we suspected we have multiple differential diagnoses, whether it was a neoplasm or an infectious origin. So we got this, we suspected because the area which he came from, Sunsari district, we have lots of cases of Japanese encephalitis, so we got his serum antibody check and it was positive for Japanese encephalitis. And we even got NMDA receptor done, but it was negative, which would signify it was autoimmune. But it was not an autoimmune process, but it was because of Japanese encephalitis. And then finally, high dose of steroids were used and the patient is doing better right now. So one needs to have our own level of assessment. We should not rely completely on what others have assessed. So there's lots of literature supporting encephalitis whether it's autoimmune or viral, many a times they can present with neuropsychiatric symptoms, and they can present to different range of practitioners, even to a physician or a psychiatrist or a neurologist. So we should always keep our minds open while assessing such cases. And the last one, frontotemporal dementia, but the diagnosis of schizophrenia, was keeping the diagnosis of FTD under mask and under saddle for so many years. So he was basically 54 years old. He actually presented with a movement disorder. So just to rule out cervical myelopathy, we got MRI head done with a cervical screening. But what we see was quite shocking. As you can see that there is no temporal lobes at all. Completely atrophied. And this is the T2. And even the T1, you can see it's completely atrophied. So basically right now he's 54 years old. He was diagnosed as a case of schizophrenia 15 years ago. So basically the finding in this case was the frontotemporal atrophic changes had actually started 15 years ago, which was actually giving rise to all the symptoms of delusions and hallucinations which the patient was having. So it was not actually a schizophrenia. So it was a frontotemporal dementia which had started 15 years ago. And that was the glitch in this case. So he was being treated in the line of schizophrenia for all these years. Finally it turned out to be a frontotemporal dementia. To support my findings, I put up a study, psychosis and behavioral variant. There's something called as a behavioral variant of frontotemporal dementia, which presents with, most of the time it presents only with psychosis and delusions. So these are the 4 cases of interest, which were difficult to delineate whether it was a functional or organic, but with a thorough evaluation and a detailed history taking, it was finally unraveled, neurologic or functional. So finally to conclude, there is no shortcuts in clinical evaluation of the patient. Detailed history taking and chronological sequence of events will unravel the most of the enigmatic clinical cases. Psychogenic origin of symptoms can be seen mimicking various neurological illnesses. Even psychogenic stroke was very soft to see that. Psychogenic stroke, Parkinson's disease can have psychogenic presentations. Facial pulsation paralysis and psychogenic non-epileptic seizures we are quite aware of. While false diagnosis can lead prolonged and unnecessary instrumentations, exposure to hazardous effects of medicines and procedures. Thank you so much for listening.
Dr. Ashish, thank you very much. Questions? We are running out of the time. Yes, sir. You are welcome.
Thank you, Dr. Ashish. It was an excellent presentation. In fact, all the cases are fantastic. I'm just talking about the first case. The symptoms was left-sided hemiparesis with left-sided facial palsy, right? But sometimes you know that when the extrapyramidal tract is crossing, 20% of the cases are in the same size. So might be one of the, maybe the rare cases, it can happen, number 1. Number 2, yes, you are right, that MRIs can at least we got an infarction. Otherwise, there are lots of stroke. In the CT scan, if there is an infarction, the CT scan report was normal. That is just I want to mention that it can try to understand that it might be to exclude organicity. You have to be 100% sure that there is no.
I fully agree. Thankfully agree. Thank you so much for your answer.
Running out of time. Thank you very much, Dr. Ashish. There is no shortcut.
Thank you.
We need to detail evaluations. So moving to another, we have another Dr. Jasmine Ma. She is going to present emotional and behavioral problems among Netflix school-going children. Dr. Jasmine.
My name is Dr. Jasmine. I'll be presenting on the emotional and behavioral problems among Nepalese school-going children. And the content of my presentation will be background, methods, results, and conclusion. Regarding the background, this research primarily focused on emotional and behavioral problems of children and adolescents in Nepal. Mental health is shaped to a great extent by social, economic, and environmental factors. And environmental adversities increases the risk of mental health problems in children. We all know that. And Nepal is classified among the low and middle income countries. And unfortunately, children and adults in Nepal are exposed to many such factors. The government of Nepal has allocated less than 1% of its total health budget for mental health, with a negligible portion of this amount dedicated to child and adolescent mental health services. and the country still has no official child and adolescent mental health policy, and child and adolescent mental health services are poor, with only one outpatient clinic devoted to the services in the whole country, and no inpatient facilities. Therefore, with this background, we wanted to do a large-scale studies, and up till now, no large epidemiological study on the magnitude of emotional and behavioral problems in Nepalese children has been published in the international literature, and not much research has been done on the association between family risk factors and child emotional and behavioral problems in lower and middle income countries, including Nepal. And the present study is also the first to compare the level of teacher and parent reports on child EBP and parent-teacher agreement ratings in Nepal. The aims of the study was to assess the prevalence and magnitude of emotional and behavioral problems in children and adolescents as reported by parents and teachers, is to assess the prevalence and magnitude of emotional and behavioral problems among children and adolescents as reported by parents and teachers, to assess the association between family variables and child emotional and behavioral problems, and to examine the agreement between parents and teacher reports of child EBP. Before commencing to the study, we took ethical approval from the Ethical Review Board of Nepal Health Research Council, and both collection and storage of data were done according to their rules, and confidentiality was maintained. Consent was sought from the caregivers. And in the method, we purposely selected 3 districts from the mountain region, 6 districts from the middle hills, and 6 districts from the Tarai region, plus the Kathmandu district, based on the population distribution of Nepal. That is, 16 districts were in total were selected. And 4 schools, 2 government schools and 2 private schools per district was purposely selected. That is a total of 64 schools. 32 government and 32 private schools were selected. And 6 children, 3 boys and 3 girls, irrespective of the ethnic background, were randomly selected from grades 1 to 10 using random number table. That is 60 students per school were selected. So all in all, 240 children per district were selected, with a total of 3,840 children from 16 districts. And data collection was done from September 2017 to January 2018, and the overall participation rate was 99.5%. The measure used were child behavior checklist and teacher report form that was translated and adapted into Nepali language, and background questionnaire, semi-structured interviews. Regarding the child behavior checklist, there are 118 specific items which are scored on the 3-point Likert scale of 0, 1, and 2, plus 2 open-ended questions. There are 90 common items between TRF and CPCL. There are 8 syndrome scales: withdrawn, somatic, anxious, depressed, rule-breaking behavior, aggressive behavior, social problems, attention problems, and thought problems. The syndrome scales are further condensed into 2 broadband scales: internalizing problems, externalizing problems, and the total problems. Statistical analysis was done by ANOVA for a group comparison of mean scores on the different problem skills as reported as parents and teachers. Bivariate correlations were taken, and correlations between the TRF scale scores and the CBCL scale scores were analyzed using the Pearson correlation test, and the significance level used for all tests was 0.005. In the result, in the CBCL and the TRF, the emotional and behavioral problems of boys and girls, the prevalence was 19.1% was found in the CBCL score, and 15.4 was found in the TRF scales. And the most interesting part of the study was that we found higher internalizing problems, that is 24.1% in our study. And maybe due to the lack of awareness of mental health problems among children and adolescents, the parents reported more of the somatic complaints. That is, the parents are more aware of the physical problems of the children rather than mental problems. So therefore, we can assume that the reason for high internalizing problems. In the bivariate correlation, we found parental mental illness, parental physical illness, conflict in the family, causing stress, parental disagreement in child-rearing problems, and physical punishment in children were positively correlated with both internalizing and externalizing problems. in the correlation between teachers and parent reports, we found moderate correlation in all problem scales, and higher correlation was found in the attention problem due to the fact that Nepalese parents are more focused on academic related problems of the children. Therefore, the attention problem can be correlated with that. And maybe because the parents and teacher most often talk about academic problems, that's why the higher correlation was found in the attention problem. And in the conclusion, our study showed that child EBB scores varied according to gender, and the cross-informant agreement between parents and teachers was found to be moderate and varied according to the types of problems and the child's gender. Further, the study found that child mental health problems were associated with several family risk factors, underscoring the importance of obtaining information about family correlates when evaluating and treating children in Nepal. And finally, the study points to the need to acquire information from multiple sources when assessing children with mental health problems. And the funding of the study was done by Forut and Civil Nepal. However, there was no conflict of interest.
Okay, Dr. Jasmine, thank you very much. From the audience, any comments? I think this is one of the interesting study, especially for school-going children, and anxiety, internalizing, externalizing problems are very common. 20% is almost 10. Anyway, there is no, we are running out of time. We can call the next speaker. Thank you very much, Dr. Jasmine. The final speaker is our pre-paper sessions, Dr. Robin Panta. Dr. Robin Panta.
Respected consultant psychiatrist and the resident, medical student, all the guests and everyone present over here. I am Dr. Robin Kapantov, MD first year resident, Department of Psychiatry, Gandaki Medical College and Teaching Hospital, Pokhara. Today I am going to present on this topic, opinion towards mental illness in medical undergraduate, which is the online survey. The authors of this online survey are Professor Dr. Nirmala Michani, Professor Dr. Deep Kumar Thapa, Professor Dr. Raviraj Simashina, Dr. Prakriti Pradhan, Dr. Achut Azhar, Dr. Kamal Bhandari, and myself. This is the brief overview of my presentation. Introduction. Mental health is an inseparable part of overall health and well-being. According to WHO, in 2019, 1 in every 8 people, or 970 million people around the world, were living with mental disorder, with anxiety and depressive disorder being most common. In 2020, the number of people living with anxiety and depressive disorder rose significantly because of COVID-19 pandemic. According to Nepal National Mental Health Survey, which was conducted from Jan 2019 to Jan 2020 in all 7 provinces of Nepal. Among other participants, 10% had any mental disorder in their lifetime, and 4.3% currently has any mental disorder. Among adolescents was found to be 5.2%. Many mentally ill people remain undiagnosed or underdiagnosed because they hesitate to seek medical help due to existing stigma and discrimination. Stigma exists even in healthcare system, which affects patient care. Even in medical colleges, there is lack of understanding about mental illness. For instance, some universities in Nepal do not have a separate psychiatry exam. So those universities, medical students can graduate without having knowledge of psychiatry. A separate psychiatry exam is required in some universities' curriculum. As a consequence of it, knowledge of mental illness, even after graduation, is not uniform. The goals and objectives of my presentation. From this online survey, we attempted to find out opinion of medical graduate, which will reflect their knowledge about mental illness. Using the opinion about mental illness scale, OMI, Cohen's training, 1962, 5 attitudinal dimensions were investigated, which were authoritarianism, opinion that people with mental illness cannot be held accountable for their acts, and these to be controlled by society. Benevolence, an attitude that could be placed between tolerance and pity or compassion. Mental hygiene ideology, companion that mental illness is similar to other illness and is to be treated adequately by specialists. Social restrictiveness, opinion that mentally ill persons should be restricted in some social domains. Interpersonal etiology, belief that the real cause of mental illness is problematic interpersonal relation. The methodology, this is an online survey using standardized survey questionnaire by using the following link. Circulated to all medical undergraduate over Nepal. Survey is based on OMS scale by Cohen and Sterling. The study period was from 15 August 2022 to 15 October 2022. Total of 298 responses from different medical undergraduate students all over the Nepal. Data tabulated in Microsoft Excel and statistically analyzed by using SPSS software. The study design was cross-sectional and the study population were medical undergraduate and ratings instrument was OMS scale. These are the survey questionnaire. There were total 27 survey questionnaire, which I will be discussing in the result. So 52.3% of the medical graduate who responded were from age 21 to 25 and 64.4% were female and 82.2% were Hindu and 52.7% were MBBS student, and most of them were posted in medicine department. When asked, do you have any family member with mental illness, 61.7% replied no. So these are the questionnaire. Locating mental health facilities in residential area downwards the neighborhood, 52% strongly disagree. It is frightening to think of people with mental problems living in the residential neighborhood, 38.9% disagree. I would not want to live next door to someone who has been mentally ill, 41.3% strongly disagree. A woman would be foolish to marry a man who has suffered from mental illness even though he seems fully recovered, 35.9% disagree. Anyone with a history of mental problems should be excluded from taking public health, 44.6% strongly disagree. People with mental illness should not be given every responsibility, 47.3% disagree. People with mental illnesses are a burden on society, 58.1% strongly disagree. As soon as a person shows signs of mental disturbance, he should be hospitalized, 30.5% disagree. We have a responsibility to provide the best possible care for people with mental illness, 65.4% strongly agree. Virtually anyone can become mentally ill, 49.7% agree. Increased spending on mental health services is a waste of money, 65.1% strongly disagree. People with mental illness don't deserve our sympathy, 64.1% strongly disagree. We need to adopt a far more tolerant attitude toward people with mental illness in our society, 36.9% agree. People with mental illness have for too long been the subject of ridicule, 36.2% agree. As far as possible, mental health services should be provided through community-based facilities, 44% strongly agree and 45.3% agree. People with mental illness are far less of a danger than most people are supposed to. 42.3% agree. Less emphasis should be placed on protecting the public from people with mental illness. 31.3% are neutral and 31.3% disagree. So I will be I will be going to the conclusions of this online survey. To conclude, this study showed that medical undergraduate students of different medical colleges have more authoritarian attitude, are more benevolent and view mental illness like any other illness. They show neutral attitude with respect to social respectiveness and interpersonal etiology. Students still have some misconceptions which can directly affect the quality of patient care they will deliver in future. Interactive and effective teaching and training program is a must to further improve the attitude towards mentally ill. The limitation of this online service, being an online survey, respondent may have misunderstood or provided incorrect information. These are the references of my online survey. Thank you.
Okay, Dr. Rovinka, thank you very much for your timely presentation. Any comments?
I just wanted one clarification. You said in some medical colleges, psychiatry exam is not there. Can you explain what does it mean?
Sir, in some universities, it is not compulsory to pass psychiatry exam separately.
Yeah, it's included in the medicine. Yes. No separate examination.
No separate compulsion to pass.
Yeah.
Yes.
But no separate examination.
No separate exam.
Anything more? If not, sir, from your side, cases, sir. So I think I would like to congratulate all the 5 speakers. I think I'm sure that the new residents, that the young psychiatrists, they must benefit from the presentations. I hope that in future you will have this type, same type of the research article, research presentations, and you have learned so many things. With this, from sir, on behalf of from our side, sir, I would like to conclude, and I would like to hand over the organizer further to proceed this.
To felicitate the speakers and the chairperson, I would like to request respected Dr. Mahendra Yukani to come on stage and do the honors. Thank you, sir. I would like to request Dr. Abbas Niraula to come on stage. Thank you, sir. I would like to request Dr. Ashish Tata to come on stage. Thank you, sir. I would like to request Dr. Jasmine Ma to come on stage. Thank you, ma'am. I would like to request Dr. Robinka Pant to come on stage. Thank you, ma'am. I would like to request Professor Dr. Nagaraj Koirala to come on stage. Thank you, sir. I would like to call Professor Dr. S.P. Ojha to come on stage. And existing challenges. Dr. Prerna Jha is going to present on the topic Study of Suicidal Intent, Psychosocial Factors and Psychiatric Comorbidities in a Patient with Suicidal Attempt. And Dr. Bigya Shah is going to present on the topic Developing and Providing Video Conferencing Services in Patan Hospital, a retrospective study. Take their seats as the chairperson of this session. Thank you.
Good evening, respected seniors, teachers, colleagues, and friends. So, the topic that I'm going to talk about today is just too much for a 5-minute talk, but I'm trying to squeeze it down to the essence of drug policy in Nepal. From what I understand, drug users in Nepal are thought to be people that are criminal, that are bad people, that are morally unsuitable for the society, and our policies have been straightforward and bang on target to put them behind the bars and make sure that they don't reintegrate into the society. So in this regard, I want to present the situation where we will learn about what are the existing major policies in Nepal. We will dissect some existing policies in terms of loopholes, and then we'll also suggest some
reforms that these policies need. So in a nutshell, drug use in Nepal is ever expanding. I've been in core of drug addiction treatment for quite some time, and I realize not even in clinical practice, but in day-to-day practice and in society, drug use has actually increased. From data by Ministry of Home Affairs in 2020, about 130,000 drug users are there in the streets right now. Worrisome part, more than 2/3 or 3/3 are less than 30 years, and about 80% of them are polydrug users. When you look into policy reforms, Ministry of Home Affairs comes in, and you don't find any picture of Ministry of Health and Population. We believe as psychiatrists and mental health professionals that drug use is a medical problem, and that too a psychiatric problem, and it has to have mental health interventions. But if you look for policies, Ministry of Home Affairs is using all their power, and it has been a culture in Nepal where they talk about Niti Tarjuma, Niti Nirdharan, and they also have their policies for rehabilitation centers. So these are all the kind of activities that Ministry of Home Affairs do, and they're doing quite well. Not to just negate them or, let's say, criticize them for their activity. We have to be aware that Ministry of Home Affairs has a journal for addiction disorder that has been there for a long time, and Professor Oja, we actually contribute on a regular basis on that journal. So there are a lot of activities in regard to supply reduction, demand reduction, and all these activities that happen on a regular basis. If we go into all these oins and karyavidhi, we can go on discussing for hours and hours, but one of the most driving and discussion needed document is the National Narcotic Act, which is quite old, maybe older than me, and maybe older than a lot of you. And there are other important acts. So the core agenda of this act is put them into bars, put them away from the society. They are exclusively focused on legal categorization of drug use. But we know addiction is a health issue, and existing policies fail to address that. So the policy approach has been so punitive that out of all people that use drugs in Nepal, about 45% of them have been arrested. And if you go for injecting drug users, about 63% have been actually arrested in their lifelong. They have been denied of treatment. And the treatment is punishment, incarceration, and punitive approach. So my agenda is support, don't punish, but our way of action is punish, don't support. So I can go into detail of all these stuffs, but there is no broad definition of what a Lagu Ausad means. The Nepal Gazette does not update the drugs that are available in the market. For example, if you are a clinician in the field, young people are using tapentadol now. They're not using tramadol anymore, but our Gazette does not recognize that. And sometimes there's collision between the legal and the clinical terminology. And there are other differences, like our policies have contradicting definitions for Durbeshan and Upachar Tatha Punarstapana Kendra. The existing documents still don't recognize medical colleges and Upachar or hospitals as adequate Upachar Kendra for drug use. So what I want to say in this slide is we have been so punitive that out of all the offenders in the prison right now, 21% of them are actually drug offenders. And these are actually the people that had to be treated in our clinics, in our hospitals, and not just be kept into prison. In regards to Gaza, I want to say, if you have used cannabis once in your life, you are punishable by law. Up to 2,000 rupees and 1 month in imprisonment. The recent advances or the recent development in the proposal says possession can be decriminalized, not legalized, but the existing policy says you can be kept inside the bar. The other interesting thing is you can actually be kept into a rehabilitation center without your consent if your parents can catch you hold with cannabis. The situation is even more grim if your parents catch you with opioids, because in that situation you can be taken into prison for 3 months and nobody is allowed to meet you. So such punitive are our treatment policies, And the Ministry of Home Affairs has a opioid substitution treatment and there is no referral mechanism. So, हामी कहाँ कैद हुन्छ उपचार हुँदैन. And this is a missed opportunity and we have to do something about this. So, the Raghu Ausad Rashtriya Niti says prisons has to be seen as places of treatment. There is no prison mental health programs, and so we have talked about this in policies but not in actions. In regards to Upachar Tatha Punarstapana Kendra, we know they are sorely run by people that have past experience, no psychiatrists, but they've been something that has been done. With the newer guidelines, we have tried to be proactive and at least mention that there are important stakeholders in mental health that need to be in these treatment centers. For example, Lagu Ausad प्रयोगकर्ताको लागि उपचार तथा पुनर्स्थापना केन्द्र निर्देशिकाले नेपाल सरकारले लगानी गर्नुपर्छ भन्छ, नेपालको प्रदेशले लगानी गर्नुपर्छ भन्छ, एनजिओले पैसा नकमाइकन चलाउनुपर्छ भन्छ, तर हाम्रो रिहाबहरू पैसा लिएर व्यक्तिले आफ्नो खल्तीबाट उसको परिवारले पैसा तिरेर उसको उपचार भइरहेको अवस्था छ. And we are just looking and maybe wanting to do nothing about that. There are contradictory messages in regards to Punarstapana. The one guideline talks about in a certain way, the other guidelines talks in a certain way. Some guidelines say that you can actually keep someone in prison without their consent. Some say that abhibhavak ra samrakshakko zimmewari chahiन्छ. So actually they are being played upon. Who bears the cost? State? No. So families members are actually smuggled to, or maybe they are actually blackmailed to pay their costs. And we know rehabilitation centers in Kathmandu cost about lakhs in a month to as less as few thousands in a month. Now there are some advances that we have done because of our hard work. They talk about having a psychiatrist, a clinical psychologist, or at least a medical officer in a rehabilitation center. And this has been our advance. But is someone monitoring this? I would say no. There are 235 rehab centers in Nepal that are actually using torture as treatment and violence as therapy. But now we are creating modalities where we have actually a mechanism to monitor them, but how to ensure uniformity, we need a narcotic drug control policy. And what this proposes is all rehabilitation centers should have uniform guidelines for the management. There should be a psychiatrist. They should collaborate with a psychiatric unit if there are more than 5,000 drug users in a local level. And these are exciting prospects for us. So in regards to the narcotic drug prevention control master plan, we have to make partnership. We have to partner with Ministry of Home Affairs, Ministry of Health, community-based organizations like Recovery Nepal and Psychiatric Associations of Nepal has to pick up. Because if we don't work for people who use drugs, nobody's going to work in a scientific evidence-based. And last note, drug addiction can affect each one of us and family members of each one of us. So it is so important that we should have policies that are evidence-based and scientific. With that, I end my presentation. Thank you very much.
Thank you, Dr. Shagun. Nicely presented. Yes, of course, it's a chronic disorder and we should support, not punishment. Any comments?
Thank you very much, Dr. Shagun. I think this is a national conference and we are here and we have also Dr. Saha, the guests from the other countries. And we cannot just simply blame our government because drug policies, there is a need of reform, that is there. But we are as a technical person, I think we need to give our recommendation to the government. Because as you mentioned, Dr. Shagun, thank you very much, that this addiction is a medical disorder and we have to look after the all biopsychosocial model. And as you mentioned, we have a plenty of rehabilitation center in Nepal. And we need kind of protocol, or national protocol. We are running a de-addiction clinic in our departments. So one of the policy maker who thinks that we are running the rehab center, we are actually running the addiction center. Just 2 weeks, 2 to 3 weeks detoxification center. So even in our institute, the policy maker, they don't know whether this is detoxification center, whether this is rehabilitation center. So I think from today's conference, we need to give recommendations to the government. We need to sensitize because government has many challenges. Even the Minister of Home has many challenges. So I think we can give a recommendation so that we can change the new drug policies and that can be implemented in the country so that the people suffering from drug addiction problem, they can be treated as a medical problem, model. Anything, sir, from your side?
It's good, really, I do agree with you, sir, Dr. Saraj, because we have to recommend, and whatever, it is an excellent presentation, by the way. And you are absolutely rightly indicate the point that we should support them, not only punish, but there are some legal confusion as well when they treat. They are not arrested for a single reason. There are lots of other reasons are there, because we worked on this in India too. But there is, in India also, there is a rehabilitation center. Those who recovered from this addiction problem, they are given to the license to open a rehabilitation center. That is a main headache right now for us, because that was not particularly treated, and one proposal we have given, that is absolutely right. There should be standardization of the all rehabilitation center. Minimum criteria should be there, one psychiatrist, and how to treat this type of patients, how to manage this type of patient, that should be. Thank you so much.
Thank you, sir. Dr. Sagan, it was a wonderful presentation, and it is very important topic that we have to us, but we least talk about. So PAN is always ready to support in this kind of thing, because we know the addiction problem is getting bigger and bigger in current scenario. So the PAN is always to support it, but we need to talk about this presentation. We can do this presentation in a large forum. We can include the Ministry of Home Affairs and even law enforcement and even the Ministry of Health and Education as well. So the PAN is always there to support.
I am ever ready to support from my part. Thank you.
I would like to request Dr. Prinaja to present her presentation, Study of Suicidal Intent, Psychosocial Factors and Psychiatric Comorbidities in a Patient with Suicidal Attempt.
Even in evening time. I'm Dr. Prinaja, and today I'm going to present on the topic Study of Psychosocial Factors, Suicidal Intent and Psychiatric Comorbidities in Patients with Suicidal Attempt. Moving on to introduction, suicidal attempt is the common clinical problem in all over the world, and Nepal is definitely not an exception. In Asia, at least 60 million people are affected by suicide or attempted suicide in each year. Despite this, suicide has received relatively less attention in Asia than in Europe and North America. The small South Asian country Nepal was ranked 7th by suicide rate globally by 2014, and over 5,000 Nepalese commit suicide every year, according to a review of the Nepal Police 5-year data, which shows a steady rise in numbers. So the aim of the study is to explore psychosocial factors, identify suicidal intent, and psychiatric comorbidities in patients with suicidal attempt. Specifically, to study spectrum of psychosocial factors in patients with suicidal attempt, to identify intent of suicide, to study different psychiatric comorbidities in patients with suicidal attempt, and to study the socio-demographic factors associated with suicide. Methodology: total 265 cases were enrolled from various clinical departments of UCMS teaching hospital. Consent was taken from both patients and the informants. Various scales were used, like Base Suicide Intent Scale for suicidal intent, Mini-7 to find out the psychiatric comorbidities, IPD to find out the personality disorder, Presumptive Life Event Stressful Scale to find out the stress, and also adding the Bronfenbruner socio-ecological model for stress. So results of my study were, majority were females, that is 51%, married population accounted for 62.3%, Hindu religion followers were the highest, 65.5% were illiterate and maximum were unemployed, majority attempted suicide at home, and 2/3 of patients lived in nuclear family. If you talk about the age group, as we can see in the bar diagram, maximum were between 20 to 29, followed by below 20, then least were 50 and more. But if we talk about the association, more the age, more were the suicidal intent. During the assessment of the psychiatric comorbidities, majority were having major depressive episode current. If you talk about base suicidal intent scale, majority were in between the moderate suicidal intent, followed by low and then severe. So poisoning was the most common mode of attempting suicide, followed by hanging. Majority had moderate suicide intent, that is 48.1%. 58.1% suicide attempters had psychiatric comorbidities. Majority of the patients between 16 to 49 were found to have median suicidal intent, and more than or equal to 50 had maximum of highest suicidal intent. Maximum patients from both sexes had diagnosis of major depressive disorder. Male had more diagnosis case of alcohol use disorder. Significant association between base suicide intent scale and PLESS is and suicide intent was found. Means more the is, more the stress was the finding. In this study, 48% of the subjects had moderate suicide intent and 29% had severe suicidal intent. As reported by Pradhan et al., moderate suicide intent was seen in the majority of the patients. In the present study, 47.2% found to have personality disorders. Majority of suicide attempters had impulsive personality followed by borderline. In accordance with the findings in this study, similar result was found in study conducted by Brent et al. Results suggested that suicide attempters were much more likely to have had a probable or definite personality disorder, most commonly cluster B, impulsive type followed by cluster C, avoidant dependent. So the strength of my study is studies exploring the area of psychosocial factors, suicidal intent, and psychiatric comorbidities in suicidal attempts, especially notifying the western region of Nepal as scanty, and this study attempts to address the pandemic issue as well. These are the few references. Thank you.
Thank you for a nice presentation. Now I will take 2 comments or questions. Anybody please, sir?
Thank you for excellent presentation.
Thank you, sir.
One comment is regarding the statistics, I mean gender. You said that it is almost same, male, female, because 51% is female, then it means 49%, right?
Yes, sir. 51, yeah, with 2% female is winning.
So it is almost same, but if you see I compare to India, and globally in the Western countries, male are more commit suicide. I mean 1.6 to 1%, and in India it is 3:1 for female. Female are more common. So what I am saying, it is in between. That is a just notice.
Thank you, sir.
Thank you, sir. The study is very important in our secondary region because of every day 18 suicides, and every day 10 times of the suicide. That means 180 or 200 persons attempting suicides, and most of them are the female.
Yes.
But in the study, almost similar. In world, yeah. So keeping these facts, and we are talking about our national conference, and we need to give the recommendation to the government, at least. The reason because every day this is the huge public health problem. So this is a very interesting study. I think we need to, make a recommendation that there are certain factors, socio-demographic factors, which are relevant. If we can educate, if we can aware the people that attempt suicide can be prevented. Another point is the comorbidity. Every day, when there is a mass suicide, the media asks us, what is the cause of suicide? So the psychiatric comorbidities are important, which you have mentioned. I think these are the things we need to aware the people, we need to aware the media, so that will be, the positive, we can prevent in the line of suicide. So thank you very much, Prerna.
Thank you so much.
Dr. Sudarshan.
Thank you very much, Dr. Prerna, for your excellent presentation.
Thank you.
Definitely, there is no doubt the society is in an alarming condition right now in Nepal. It is day by day it is increasing, and your study has also shown that this is not only suicide, this is the attempted suicide that we have done. And it shows the suicidal morbidities also definitely. And I think in your presentation in the last day that we have to be very, give the guidelines to the government, and for that the preventive strategy of suicide is also one of the important factors which we need to improve, incorporate, and then to send it to the government, and so that they will be because they have a lot of cases of the suicide cases. They don't have attempted suicide cases. Attempted suicide used to see by we psychiatrists. So that's why these things we have to keep it in our mind. Okay? Thank you.
Thank you, sir.
Thank you, sir.
Dear Shah, respected chairpersons and dear audience, I hope I can take you along to this new topic which I'll be talking on, developing and providing video conferencing service in hospital, Patan Hospital, or retrospective study. I have nothing to disclose. Well, telepsychiatry is the use of electronic communication and information technology to provide psychiatric care at a distance. We can either use telephone or video media, that is through WhatsApp Viber. Well, digitalization of mental health directly supports by making the service widely available, and we can also provide evidence-based treatment at a distance. And it's especially valuable in lower and middle income countries where we are short of health professionals and there are hard to reach areas, no availability of health centers nearby. Before COVID, like telephone consultation has been there since years in our society. You always get calls from people and when we advise to them. There were brief telemedicine and telephone consultations which was structurally done under collaboration of Ministry of Health and Population with various other institutes, but it could not sustain. And there has been various helpline numbers. Everyone must be aware about the long list we have. But when COVID-19 has occurred, the pandemic, everything was on hold. The health services stopped. That's when new helpline numbers were established. Similarly, various institutes, right, from NGOs, INGOs, even our very own PAN, private clinics, hospitals, started telephone video conferencing services, out of which, for now, if we see government hospital, then there are only two where such service is running. One is being done for police officials in police hospital, and next for the public in Patan Hospital. So the objective of my study are to discuss on development of video conferencing service in a public hospital and to explore profile of patients and to identify benefits and challenges of the service from patients and patients' perspective. We designed a new system for video conferencing after incorporating findings from review of literature, existing health services, and also feedback collection from various mental health professionals in my department. And this is the setup where we have a person who books the appointment. There is this room where we have a small setup where we do video conferencing through WhatsApp and Viber. And it is the usual setup. It can be found anywhere, in the office or our homes. But what we need is a good quality web camera and headphone with microphone. We also designed the prescription note, and because we didn't know what we were looking for, because there was not much published and we didn't have such service earlier, so we also designed the feedback form and we would send the link online once consulted. The online service runs currently twice a week, and it runs just for 2 hours in my hospital. And for the for the talk program, I did a retrospective review of the ongoing service, which of last 15 months only. And the findings show that so far we have been able to, consult 146 calls and help 62 patients. Majority were follow-up cases. Around one third were the new cases. Majority did a single consultation, and as many as 3 did 8 times consultation. And the majority of the population belonged to 18 to 49. We helped as young as 14 years and as elderly as 89 years patient. Majority were males residing outside Kathmandu Valley. And this shows that we have been able to serve people from right across Nepal, in the west as far as Mugu and Kanchanpur, and in the east as far as Sunsari. And the majority of the diagnoses were anxiety disorder, OCD, mood disorder, psychotic disorder, migraine, headache, extrapyramidal symptoms, and so on. Majority didn't have past history of psychiatric illness, nor majority did have medical history, nor family history of psychiatric illness. Very few had substance use history. Majority didn't follow up, and we could only provide psychoeducation, sleep hygiene, and supportive psychotherapy sessions as a part of the video conferencing service. Majority of the medicines used were SSRIs, antipsychotic benzodiazepines, and the feedback result was really striking. The patients did perceive that there was a short waiting time for the video conferencing. They found that compared to in-person, psychiatrists gave more time. It was more easy booking process. The clarity of conversation was similar. They had convenience to buy psychotropics. They preferred such telepsychiatry service even for the first time and follow-ups. And overall, they found it easy. And yes, they would opt for even payment options if required for future, because our service was actually free. The limitations were, it was very limited just for 2 hours for 2 days in a week. There was shortage of manpower, to run OPD and telepsychiatry service as well as make the appointment. Technical issues in terms of digital literacy or internet connection issues, verifying identification of the patient would be a problem. Similarly, ensuring privacy of the patient would be problematic at times. We couldn't provide comprehensive service such as, we can't do physical examination here. We could not provide structured psychotherapy sessions, and it would take long time to consult single patient, and there are no case managers between patient and mental health professionals to connect. So we don't know what happens beyond the virtual space actually. So yes, it's difficult. We have difficult topography, poor transportation, natural disasters, political instability, frequent road blockage, but there is good telephone coverage in Nepal that makes telepsychiatry a convenient option. However, digital literacy and internet facilities can remain a challenge. The socio-demographic and the clinical profile of the patients was similar to other studies. There was only a single study published from Eastern Nepal and we had the similar finding. However, the number of patients in my study was less because we are in Kathmandu where there are many options for a patient to seek service, and there was logistic issue. Just 2 days in a week we would run the service. So despite the challenges at patient, clinician and medium level, we need professional training, supervision, technological assistance and backup, ethical consideration, research and effective guidelines to run it smoothly. So we call for a collaborative approach between government, international bodies and stakeholders. The study was limited to a single hospital and small sample size. So yes, we need video conferencing. It can complement the ongoing psychiatry service, and it is possible to establish in all the hospitals. While there are challenges, we have plenty of opportunities to help patients from hard-to-reach areas and to improvise their satisfaction. Thank you so much. I'd like to thank the important people who have really helped me to run the service and then contribute to my understanding about the service in Nepal. Thank you.
Thank you, Dr. Bigyan, for a nice presentation. Any comments and questions, please? Anybody? Nobody? Third answer, please.
This is the brain, especially after COVID pandemic. This is very, very effective because especially country like Nepal, well, access is very, treatment gap is there, and this is very convenient, cost effective, and thank you very much. Yeah. I think I'm sure that in the coming days we move forward this type of telepsychiatry services in Nepal. I think that's all from my side. Thank you.
Thank you, sir. So if you have any questions, I think we should complete our session. Yeah? Nina? Okay.
Thank you.
Do you have any problem?
Wonderful presentation, Dr. BK. We are already running out of time, so I think it should be on time.
Thank you, Dr. Neena Rai and Dr. Rajan Sharma. To felicitate the speakers and chairpersons, I would like to request respected Dr. Gautam Shah to come on stage and do the honors. Thank you, sir. I would like to request Dr. Prerna Jha to please come on stage.
Sir, excuse me, sir.
Thank you, ma'am. I would like to request Dr. Vidya Shah to come on stage. Thank you, ma'am. I would like to request Dr. Neena Rai to come on stage. Thank you, ma'am. I would like to request Dr. Ravin Sharma to come on stage. Thank you, sir. Thank you, Dr. Gautam Shah. I would like to request all the presenters to please come on stage for the group photo.